Pharm is an industry-leading pharmaceuticals company with a proud heritage of over half a century of experience in delivering cutting-edge technologies to produce the highest quality medicines. Pharm is breaking boundaries and challenging industry norms in the pursuit of excellence. To fulfill this purpose, a clear vision of future expansion has come to fruition through multiple alliances and partnerships with specialized companies around the world.
We at Pharm established the first research community in Egypt and the Middle East. Our team is composed out of young, talented Egyptian scientists and European experts. Together, we develop high-quality and cost-effective genetically engineered drugs.
The development of complex genetically engineered medicines in Egypt is supported by Pharm's German subsidiary, a global provider of intelligent proprietary technologies for the biotech industry at large, with a firm commitment to breaking down scientific and economic barriers.
There is substantial evidence that a new age is dawning for Egypt to offer exceptional opportunities, and Pharm is perfectly positioned to ride into the future with life-saving and life-enhancing, innovative and yet affordable products.
Striking the balance between innovative and affordable medicines is the mantra at the company's core, allowing Pharm to play an important social role by responding to the complex challenges of unmet medical needs of emerging countries. Pharm's desire to overcome these challenges helps the dreams of the next generation to be fulfilled. Pharm is an industry-leading pharmaceuticals company with a proud heritage of over half a century of experience in delivering cutting-edge technologies to produce the highest quality medicines. Pharm is breaking boundaries and challenging industry norms in the pursuit of excellence. To fulfill this purpose, a clear vision of future expansion has come to fruition through multiple alliances and partnerships with specialized companies around the world.
We at Pharm established the first research community in Egypt and the Middle East. Our team is composed out of young, talented Egyptian scientists and European experts. Together, we develop high-quality and cost-effective genetically engineered drugs.
The development of complex genetically engineered medicines in Egypt is supported by Pharm's German subsidiary, a global provider of intelligent proprietary technologies for the biotech industry at large, with a firm commitment to breaking down scientific and economic barriers.
There is substantial evidence that a new age is dawning for Egypt to offer exceptional opportunities, and Pharm is perfectly positioned to ride into the future with life-saving and life-enhancing, innovative and yet affordable products.
Striking the balance between innovative and affordable medicines is the mantra at the company's core, allowing Pharm to play an important social role by responding to the complex challenges of unmet medical needs of emerging countries. Pharm's desire to overcome these challenges helps the dreams of the next generation to be fulfilled. Pharm is an industry-leading pharmaceuticals company with a proud heritage of over half a century of experience in delivering cutting-edge technologies to produce the highest quality medicines. Pharm is breaking boundaries and challenging industry norms in the pursuit of excellence. To fulfill this purpose, a clear vision of future expansion has come to fruition through multiple alliances and partnerships with specialized companies around the world.
We at MENA Farm established the first research community in Egypt and the Middle East. Our team is composed out of young talented Egyptian scientists and European experts. Together we develop high quality and cost-effective genetically engineered drugs.
The development of complex genetically engineered medicines in Egypt is supported by MENA Farm's German subsidiary, a global provider of intelligent proprietary technologies for the biotech industry at large, with a firm commitment to breaking down scientific and economic barriers.
There is substantial evidence that a new age is dawning for Egypt to offer exceptional opportunities, and MENA Farm is perfectly positioned to ride into the future with life-saving and life-enhancing, innovative and yet affordable products.
Striking the balance between innovative and affordable medicines is the mantra at the company's core, allowing MENA Farm to play an important social role by responding to the complex challenges of unmet medical needs of emerging countries. MENA Farm's desire to overcome these challenges helps the dreams of the next generation to be fulfilled.
Dear colleagues and audience, based on the webinar characteristics, good afternoon, good evening, and good morning, wherever you are. My name is Mohammed Fauzi, and I'm speaking to you from Egypt on behalf of the organizing committee of Upper Egypt Reproduction Group. In this pleasant occasion, I'm talking to you from a small town at the south of Egypt, which is 100 mile south to the place of the birth of our legend. Professor who will start the first talk is Professor Mohammed Bidawi. Professor Mohammed Bidawi is a professor and division head of reproductive endocrinology and infertility department of obstetrics and gynecology, Faculty of Medicine at the University of British Columbia, Vancouver, Canada. Dr. Bidawi is double board certified by the American Board of Obstetrics and Gynecology and Reproductive Endocrinology and Infertility. He is also a fellow of the American College of Obstetrics and Gynecology and a fellow of the Royal College of Physicians and Surgeons in Canada. Dr. Bidawi is a prolific author of over 375 peer-reviewed papers, abstract book chapter, and videos. He also is an associate editor of Human Reproduction, and currently on the editorial board of multiple journals and the Journal of Minimally Invasive Gynecology. Dr. Bedawi has had a career-long interest in high-quality medical care, research, and education. He is the past scientific program chair of the World Congress of Endometriosis. Dr. Bedawi research is focused on advancing basic and clinical knowledge about endometriosis, recurrent pregnancy loss, uterine disorder, assisted reproduction, and early pregnancy complication. He also has interest in minimally invasive surgery and fertility preservation. Dr. Bedawi has served as chairperson of postgraduate course at SRM, and that deal with different aspects of reproductive surgery, endometriosis, and infertility. Dr. Bedawi supervised and training more than 60 medical student, resident, clinical fellow, research fellow, master, and PhD students in the USA and Canada. He is served on review committee of multiple and an oral examiner of the Royal College of Physicians and Surgeons of Canada. Dr. Bedawi has been the recipient of many international awards for surgical and research excellence at different societies from USA, Canada, Egypt, Jordan, Europe, and Australia. Dr. Bedawi received his medical degree from Asyut University School of Medicine, Egypt, where he graduated. Dr. Bedawi completed residency in obstetric and gynecology and reproductive endocrinology and infertility, clinical fellow at the University Hospital Case Medical Center, Cleveland, Ohio, clinical fellowship and minimally invasive surgery at Cleveland Clinic Foundation, research fellowship, reproductive biology and minimally invasive surgery at Cleveland Foundation, fellowship in reproductive science, University of Toronto in Canada, and has PhD from Maastricht University. Dr. Bedawi also is co-chair of Upper Egypt Assisted Reproduction Conference with Dr. Yaqub Khalf. Dr. Bedawi, he will address this night an interesting topic about normalizing and optimizing the uterus before embryo transfer. Thank you, Dr. Bedawi, for being with us this night.
Thank you very much, Dr. Fauzi, again for the kind introduction, and thank you for the Upper Egypt Assisted Reproductive Symposium for putting this conference together. So when I looked into the itinerary, I chose to speak about normalizing and optimizing the uterus before embryo transfer, because I'm joined by kind colleagues, Dr. Khalaf and Dr. Paulson, who will be addressing the endocrinology part, and Dr. Muhammad Sabri will take us through an overview of the indications and the current status of frozen embryo transfer and assisted reproduction. So here are my disclosures. And the prerequisites for a successful frozen embryo transfer are three. The first one is you have to have an embryo of good implantation potential and preferably a blastocyst that's vitrified, plus minus chromosomal screening if you are for or against a BGTA. And you have to have a normal endometrial cavity or normal uterus overall. In addition, you have to have a window of implantation, whether you have a natural window of implantation or you're inducing this window of implantation. As I said, the focus of my talk will be on normality of the uterine cavity and trying to make the uterine cavity the best way it looks before you even think about preparing it to receive a frozen embryo transfer. Inducing endometrial receptivity is simply based on two key components. Either you have an endogenous corpus luteum that you have by a natural ovulation or by stimulated cycles or modified natural cycles, or you took over from outside and suppressed the endogenous corpus luteum and prepare the endometrium with medications from outside. All of us are very aware of this figure about the endocrinology of the menstrual cycle, but what I want to focus on are the estrogen and progesterone. As you can see, the rise of estradiol that peaks before ovulation up to close to 400 picograms. That's typically what gives you the proliferative changes in the endometrium prior to ovulation. As probably you will hear from Richard that you wouldn't really need that much circulating level of estradiol to induce proliferative changes. And then it drops to a low level around the time of ovulation, yet to rise again and peak, second peak around the middle of the secretory phase, around 250 picograms. And then starts to drop if no pregnancy is happening. As far as the progesterone is concerned, you can see that it's very much nil in the beginning part of the follicular phase and starts to rise briefly before ovulation. And then you have a mega level of progesterone in the circulation around the mid-secretory phase, up to 10 nanograms per ml. So these changes, endocrine changes, are followed by histological changes in the endometrium as well as molecular changes as well that would enable implantation to happen. And if that is not landing on a normal uterus, all of these preparatory changes that happen at the endocrine, histological, and molecular level may go in vain if the uterus is not that good to respond well to these changes. So your goal at the end of the estrogen phase to get a trilaminar nice pattern of the endometrium in a normal uterus, and in the progesterone phase, whether it is natural or induced, you have to get the homogeneous hyperechogenic pattern of the endometrium prior to deciding to put your embryo back in. So with all of that in mind, the uterus can be challenged anatomically, functionally, or at the molecular level or endocrine level. I am going to focus only on the anatomic part because the other parts will be covered by my colleagues. And also I'm going to focus on a few of the anatomic parts because there are too many to go through. But before that, I want to share with you that uterine anatomic defects are more likely to cause recurrent pregnancy loss and maybe recurrent implantation failure rather than infertility. So with a dysmorphic uterus, you can have a pregnancy, but this pregnancy may not continue to give you a live birth, which is the ultimate goal and what we want in our patients undergoing assisted reproductive technologies. So it's not enough to have a positive pregnancy test or ongoing pregnancy as an outcome to decide about how suitable the uterus is. It's quite important for the uterus to carry the pregnancy to term. So here's what a normal anatomic uterus would appear in an MRI. Beautiful endometrium, normal uterine muscles, and normal serosa on the outside. When we go and try to evaluate, we can see the entire spectrum of abnormalities inside the uterus as small as this tiny polyp near the ostium, which is probably non-contributory to any reproductive outcome, and patient basically may get pregnant without any consequences. To a larger polyp that's mostly occupying the upper part of the endometrial cavity, which would render implantation virtually impossible, or will be associated with significant early pregnancy morbidities that has to be removed. And looking at that pathology, I think the majority of you would agree with me that we can completely eliminate that and we can normalize the endometrial cavity. Again, another example of a phagotype 0 fibroid that is kind of inside the cavity that can be removed easily hysteroscopically, and then you can get more or less normal endometrial cavity as well. to this situation where you can see that the endometrium is really studded with a large number of fibroids all over the entire perimeter of the cavity, in addition to some adhesions from a prior surgery at the upper part of the uterus. So no matter what you do to this uterus surgically, and no matter how skilled you are, either hysteroscopically or otherwise, I don't think this uterus can ever go back to normal. So sometimes we have to accept the challenge and work with a suboptimal uterus and try to improve as much as we can. In addition, there are situations where you go inside the uterus and you find in a patient with a recurrent implantation failure like that one, all you find is really a significant hyperemia and increased endometrial vascularity. Turns out that this patient has undiagnosed adenomyosis that was not addressed, and that is probably contributing one way or the other to her reproductive failure. And here again, another example from a patient with recurrent pregnancy loss, actually, that the only abnormality that you found here are small micropolypi that are distributed throughout. And when you biopsy that endometrium, this patient was CD68 positive, indicative of chronic endometritis. So all it takes to fix that is hopefully a course of antibiotics for 3 weeks. Another example of chronic endometritis with subendometriotic hemorrhages in a patient with recurrent implantation failure that turns out to be chronic endometritis. So I'm just going to touch quickly on 4 items of the list I mentioned in the beginning: the fibroid, septum, Asherman, and polyps. And for fibroids, I'm going to focus only on the component that distorts the cavity. So there is unanimous agreement and different systematic reviews and meta-analyses that submucous fibroids have a negative impact on fertility, including implantation rate, clinical pregnancy rate, miscarriages, live birth rate, and ongoing pregnancy rates. And predictors of success for treatment will be dependent on fibroid at this size. If it is less than 3 or more than 4, the likelihood of recurrence is higher if you have a bigger size fibroid. And if there is any other myomas in addition to the submucosal one that you are addressing, and if there's any concurrent pathology, particularly adenomyosis, which you can figure out in situations where you have a bleeding associated with pain, that should trigger your thinking to think about adenomyosis as an associated condition. So fibroids were found to be associated with adenomyosis 25% of the time, like 25% of the time. But not all fibroids associated with adeno needs to be treated, and not all adeno associated with fibroids needs to be treated. And the figure here that I keep showing in different boxes, on the left-hand side, you see that there is a subsurface of fibroid, and there is significant increase in the size of the junctional zone of this uterus, indicative of adenomyosis. So exclusively, most of the symptoms here are coming from the adenomyosis rather than the fibroid. Well, on the other side, you have a very well-defined type 2-5 fibroid anteriorly, and you have adenomyosis posteriorly. So both pathologies are contributing to the reproductive morbidity of these patients, and both of them has to be addressed at the same time. So when we talk about treating submucous fibroids, the classical traditional treatment is transcervical resection with either a monopolar resectoscope using different distension media, or a bipolar resectoscope where you can use saline or Ringer's lactate. And as you do that, you have to be cognitive of the fact that you're using monopolar current between 60 and 120 watts, and you always start cephalad, and you walk down towards yourself rather than towards the fundus to avoid perforation until you get this entire fibroid resected, and you start to see the healthy endometrium, the pink healthy myometrium around. So there's another way of treating that, which is commonly used in North America now, which is a tissue extraction devices, or the MyoSure, which is a rotatory blade for resection and suction. And you use saline as the distension. You have a very wide safety margin with fluid deficit up to 2.5 liters. So this is again type 1 submucosal fibroid being treated with MyoSure resectoscope. As you can see here, you just this blade starts chewing the fibroid out until you get it all out and get the endometrial cavity to be normalized at the end. So when we talk about fibroids in general and reproduction, I think there is more or less an agreement and enough evidence to support removing the type 0, 1, 2, and even maybe type 3, where the endometrium, the fibroid is intramural, but it's contacting the endometrium. And there is also data from the literature to support treating the type 2-5, which goes all the way from the cavity to the serosa. There is also an agreement not to treat the type 6, 7, and 8, because most likely they would not have outcome. And most of the controversy currently and the debate is about the type 4 and 5, where they have 100% of the fibroid inside the cavity, or more than 50%, sorry, inside the myometrium, or more than 50% inside the myometrium. And that's very much what the SRM said in their guideline. So I'm just moving quickly to the next item, which is a septum. So this is a commonest Mullerian anomaly, as all of you know, and now we have evidence that there is no justification for laparoscopy and hysteroscopy for diagnosis. So the diagnosis now should be done either with 3D ultrasound, SIS, or MRI, and you have the three of them in front of you right in this picture. This is a hysteroscopy for a complete septum. You see the fibrous portion. There is a top muscular portion, and the treatment that was choosing for this case is a hysteroscopic resection using the right angle hook in order to normalize the cavity all the way to the fundus. The Cochrane review, the most recent one, 2016, by Ben Mull and his colleagues, showed that there is no evidence to support the surgical procedure in these women. And their critical analysis of the data, they said that the randomized control trials are needed, and they indicated that 2 of them are being done. I think one of them was converted to a cohort study rather than a randomized control study, and was just published in the Human Reproduction, head of print, actually, where from 21 centers around the world, they collected close to 150 cases. And they compared those who underwent resection to those who did not undergo resection, and they found no difference in the live birth rate. Well, this is still not enough evidence to vote against treating septum for patients with any kind of reproductive morbidity. And that is what the SRM is realizing in their Septum document. First, they confirmed that imaging with hysteroscopy should be the diagnostic modality instead of the traditional laparoscopy hysteroscopy. And they indicated that the incision of the septum is reasonable for patients with infertility, pregnancy loss, obstetrics outcome, poor obstetrics outcome, and may be reasonable even for patients without infertility or prior pregnancy loss. I think the debate will continue until we have a properly randomized control trial for this. Moving to the adhesions, before I talk about how to address them and the value of addressing them in this context, I want to warn you against the risks that leads to them. In a meta-analysis of more than 100 women after either spontaneous miscarriage or a DNC, they found up to 20% in trial adhesions in those patients, and over 50% of them are mild, but more than close to 50% were severe. And the worst risk factor is more than DNC. Well, I see more Asherman syndromes in North America and here where I live in Vancouver compared to where I used to see back home. But there is lots of terminations of pregnancy and DNCs that leads to this damage, or probably I am in a referral center, so my patient population is biased. But what I want to warn you against is when you terminate a pregnancy before the age of viability, try to avoid using sharp curettage, because this is what leads to destroying the basales layer of the endometrium and subsequently cause intrauterine adhesions. So when you go treat them, we treat most of them in the office. And when you go in, if you don't see these windows, you have to create them. And then you're gonna use the cold scissors, no energy whatsoever when you treat those intrauterine adhesions. And you start with the filmy ones, and you start in the middle rather than laterally. And then you move laterally to the denser type of adhesions. And then you, once you bridge that gap where there are adhesions, you find yourself in the upper part of the endometrial cavity that you're hoping to leverage the healthy endometrium at the top to creep in and cover the disease parts. Sometimes the situation is not that easy, and you really need to use ultrasound guidance to guide you treat those adhesions. If there is a complete agglutination of the endometrial cavity, you can see here on the left-hand side, this is the top of my scissor, and this is a part of the lining that's still spared, and I'm using this as a guidance while I'm pushing here blindly in order to be able to get to the healthy part of the endometrial cavity and cut the adhesions. So creating windows, using enough distension with the saline or in the office, and using the cautionary measures I just mentioned to you in order to cut through these dense adhesions, that would hopefully get you again, excuse me, to the top part of the endometrial cavity that's relatively healthy, and that way you would have lysed most of the adhesions inside the uterus. Another case here, which is kind of the extreme, where there's completely sclerotic endometrial cavity that's massively involved with significant adhesions. You're gonna go ahead and do the best you can and pray. So there are some situations where you have a dysmorphic uterus or markedly retroflexed uterus, or severe adhesions where IR guidance or amniografts can be used in order to help, although the data is limited in this direction. It is very helpful and valuable to put a barrier, although we don't have a class 1 evidence to support that. And also treating with estrogen post-treatment is helpful. This is a patient after hysteroscopic lysis of adhesions while doing a second look hysteroscopy. So reproductive functions do improve after lysis of adhesions, and the post-operative therapy appears to decrease the recurrence risk that can be up to 66%. And also cavity assessment, that has to be early rather than late, particularly in the context of severe Asherman syndrome. Polyps, I think that's the last part of the last few slides. So they are common. There's 6 to 8% in IVF population, and again, despite the the poor quality evidence, there's one randomized controlled trial, the famous Prisma Dyna one, that randomized patients to either diagnostic hysteroscopy doing nothing, or hysteroscopy and removing the polyp, and then the patient underwent 4 IOI cycles. Patients with polyp removal have a higher pregnancy rate, up to 68%, and those without 28%. So that's enough evidence to support removing polyps from the uterus. But just took the credit of my friend, Professor Khalaf. I just want to mention briefly the 2 elegant publications that they published in the Lancet back-to-back, the InSight as well as the Trophy studies. The InSight about first hysteroscopy prior to first IVF, if you have 100% certainty that by ultrasound that your uterus is healthy and normal, there is no justification to proceed to hysteroscopy prior to that. And the same goes for patients with recurrent implantation failure. So the key point here is ensuring that the uterus is completely normal before not advocating for an office hysteroscopy prior to either first IVF cycle or recurrent implantation failure. So my time is coming to an end, and I would like to conclude by sharing with you that there is a very wide variety of anatomic defects that can affect the uterus and negatively impact reproductive outcomes, particularly prior to embryo transfer. Most of these has to be at least addressed, and the patient has to be counseled about the evidence-based interventions that can help them to optimize the cavity. You have to select the appropriate imaging modality or diagnostic modality of evaluation of the uterus prior to transfer. The treatment of the majority of the anatomic defects is surgical, but in some situations, medical treatment like chronic endometritis or preparation with medical treatment like some cases of adenomyosis or adenomyosis with endometriosis would be of value in those cases. And I think that's all I got to do today, and thank you very much.
It's my pleasure to introduce Professor Richard Paulson in this webinar. Dr. Richard Paulson is a professor and vice chair of the Department of Obstetrics and Gynecology and chief of the Division of Reproductive Endocrinology and Infertility at the Keck School of Medicine of the University of Southern California. He has been the director of the fertility program since 1986. Dr. Paulson is past president of the American Society of Reproductive Medicine and served as one of the editorial board of the Fertility Strategy. Dr. Paulson has authored over 200 scientific publications and chapters and has received more than 35 research awards for scientific publication. His major research interest is reproductive aging with a particular emphasis on human embryo implantation. Dr. Richard Paulson will introduce to you today the topic of rational approach to endometrial preparation for frozen embryo transfer. Thank you, Dr. Paulson, for being with us.
Oh, thank you for having me. There I am. Thank you for having me. It's my pleasure to be here with all of you, and good evening in Egypt, and it's good morning here in Los Angeles, where I'm coming to you from. I would like to follow on what Professor Badawi was discussing, which is the whole idea of preparing the uterus for frozen embryo transfer. And whereas he talked about anatomic lesions and surgical approach, we're going to talk about hormonal stimulation of the endometrium. And I entitled this talk Rational Approach to Endometrial Preparation for Frozen Embryo Transfer because I'm very concerned that some of the new testing that's coming out, particularly then the endometrial receptivity array, is not really evidence-based, and a lot of the conclusions that I have seen coming out of that testing don't really actually make any sense to me, particularly then when they send you a report that says, oh, you need to advance progesterone by 12 hours in this direction or in that direction. I will show you that there's ample evidence that the window of implantation is quite a bit wider than that, and so I believe that all of that is really greatly overstated. But I don't want to get ahead of myself. Here's my conflicts. I don't have any. We're going to be talking about estrogen and progesterone in the context of endometrial preparation. And so our learning objectives are going to be to talk about what exactly endometrial receptivity means, talk to patients about when it is that the window of implantation occurs. And I want you to understand when it occurs in natural cycles as opposed to stimulated and artificial cycles. And I really want to stress this concept of how long the window of implantation lasts and how it can be manipulated with exogenous estrogen and progesterone. There's a lot of type 2 error, in this field. So let's talk about endometrial receptivity and what it is. I love this picture. This is from one of the Leonard Nilsson books of scanning electron micrograms. And of course, the embryo never, ever sits on the surface of the fallopian tube like it's depicted here. Remember, the embryo is always floating on a layer of mucus that prevents the embryo from actually touching down. The only time that the embryo actually makes physical contact with the surface of the endometrium is immediately prior to the time of implantation, which is when the mucus from the inside of the uterus has been taken up by the endometrial cells. You saw some of those pictures that Dr. Badawi showed you. So what is endometrial receptivity? Well, it's an essential component of embryo implantation. I like to think of embryo implantation as depending on 3 general categories of factors. The most important of these probably is embryo quality, and that is, of course, what we're chasing with stimulation and the age of the patient and so on. But endometrial receptivity plays an important role, as does transfer efficiency. So if you're going to put the embryo in the wrong place, obviously, even if the uterus is perfect and you have a perfect embryo, implantation will not occur. And I agree that it is inferred, or the concept of endometrial receptivity is inferred from conditions where this receptivity is poor, such as intracavitary lesions, inadequate endometrial preparation, and if you're outside of the window of implantation. So we'll just spend a little bit of time talking about estrogen and progesterone. They are both needed. Interestingly, estrogen and progesterone alone are sufficient. So all of the other stuff that people have been trying for years to improve endometrial receptivity has not been found to be helpful. We tried HCG, by the way, and that HCG infusion made such perfectly good sense to me, but unfortunately that did not pan out. Here's a sample protocol for exogenous estradiol and progesterone, and you're all familiar with this concept. Let's say a gradually increasing dose of estrogen over about 2 weeks, and then progesterone starts somewhere around the time of egg retrieval, if you're doing a synchronized fresh egg donation cycle, or if it's a frozen cycle, then on the extrapolated day when aspiration would have occurred. And I just want to say a little bit about the routes of estradiol administration, because I get a lot of questions of what to do if the endometrium doesn't get thick within a certain amount of time. Just remember that the oral route is subject to first pass metabolism, and the estradiol is converted to estrone and estrone sulfate very rapidly. Only about 5% of the estradiol is bioavailable. The estrogen does exist in the circulation via this equilibrium, which may be modulated by progesterone. Here's the picture, just to refresh our memories of what estradiol looks like, and then estrone sulfate at the bottom. This is not a problem, and I've been talking to our PhDs as to whether the estrone sulfate may potentially be impeding or interfering with estradiol access to the receptor, and they tell me that's not the case. But I like to use estradiol via patches, than particularly in those patients in whom the oral doesn't seem to work. And the reason is that it's much more analogous to estradiol production by the ovary. So the conversion is very simple. A 0.1 milligram patch, so 100 microgram patch, is approximately equivalent to 2 milligrams of oral. So if you're using 2 milligrams twice a day, that means you're putting 2 patches on at one time. And it produces a fairly predictable serum levels of about 100 picograms per ml, which means that 2 patches will give you about 200, and that's a very good level to get endometrial proliferation and induction of progesterone receptors. You can monitor levels if the patient is obese and you're uncertain whether she's getting enough levels. I have had patients where I had to put 4 patches on just to get enough of an estradiol level. That's the advantage of the patch. I did not have much experience with this part. About 10 years ago, I really started using it. I like it. And you see this is actually out of the package insert, and you see the upper line there is a 0.1 milligram patch. It produces about 100 picograms per ml, fairly constant over 3 days. So a serum level is meaningful. You can't really do that with oral administration because the levels fluctuate during the day, depending on how close you are to when the patient took it. I also like to be reminded that the duration of estradiol priming, how long you put someone on estrogen before you start progesterone, really has a very wide range. And there was an original study done way back in 1989 by Danny Naveau, where he tried different artificial cycles with 6 days, 14 days, and even all the way up to 5 weeks, and really found no difference in the endometrial response as measured by biochemical markers. And a recent review looked backwards at pregnancy and non-pregnancy cycles and the duration of estradiol priming, and also found no difference. So the duration can be short or long, and if you're having a hard time getting someone's endometrium to grow thicker, I really recommend, well, try vaginal, but also try a longer duration of the patches for a longer period of time. So I really want to focus on when it is that progesterone should be given in order to open that window of implantation. And the pictures you see here, some of you will recognize the histology of a proliferative endometrium on the top and a secretory endometrium on the bottom right, and perhaps you'll recognize the penopods in the center on the bottom there. Penopods are the swelling cells of the endometrium which appear at the time of implantation. And let me submit to you that the reason that they get all swollen like that is because the macromolecules that are in the endometrium must be taken up in order for that embryo to settle down on the surface of the endometrium. Just like I said at the beginning, remember the embryo does not touch the surface of the endometrium until just prior to implantation. And ask yourself, when you think about all of those secretory cells, look at the secretory endometrium on the bottom right. All of those glands are secreting mucus. Where does that mucus go? Where does it go? It has to go someplace. And the answer is, of course, it is taken up across the epithelium, and that is what brings the embryo down to the surface, and that is what makes the penopods appear. So it's a mechanical event. It has to physically actually be able to come down in order for it to oppose. Here's some more of these wonderful pictures, and they're showing you the little penopods right underneath the blastocyst as it's coming down. They do not have any receptors on them. We think this is just a mechanical aspect of the embryo coming down. And remember, the embryo makes HCG, and it's not a lot of HCG, but if you're in the immediate microscopic proximity to that blastocyst, those levels are going to be sky high and will in fact communicate to the endometrium that the embryo is here and is ready to implant. So the window of implantation is a concept that appears to be true in many other species, and here it is presented in the human. The classic paper is the one on the left-hand side, again by Naveau, looking at pregnancy and non-pregnancy cycles depending on the days of progesterone that had been given. In all of these cases, progesterone was started on day 15. So day 17 means that was a 3rd day of progesterone, 4th day and 5th day of progesterone, and they found no pregnancies here at all. People are less familiar with the follow-up study that was published in the Journal of Clinical Endocrinology and Metabolism, where they actually did have pregnancies. These are the blue bars actually throughout the luteal phase, where it seemed like it was playing much less of a role. But everyone had already imprinted the idea that there is a narrow window of implantation, and if you don't hit it during that time, you're not going to get embryo implantation. So what is the best timing? When should we be starting progesterone? Should it be on the day of retrieval, on the day before, on the day after? So I would like to answer that first by asking, what exactly does nature do? When is it that implantation, or I should say that luteinization begins so that implantation can take place? And in order for us to understand when that happens, we first have to understand what the luteinization threshold is for progesterone. What do I mean by this? What I mean by that is, you know that if the progesterone is 10 or 15 nanograms per milliliter, that you're above the luteinization threshold. And we all know that in the follicular phase, there's always progesterone around. So it's not like there isn't any progesterone. There's maybe 0.5 nanogram per mil or 1 nanogram per milliliter. Those are high values. That's 1,000 picograms per ml that is normally in the circulation. If that was estradiol, you'd have all kinds of physiologic effects, but for progesterone, there is no effect. We think that if it's less than 1.5, somewhere around there, there's no effect at all. And this was a great study done by Steve Young from the University of North Carolina, where they gave patients different doses of progesterone, achieving fairly constant serum levels, and you see them here, 20 nanograms, that was the control group, and then going down lower to see if they would get endometrial changes. And in fact, the histology is normal all the way down to 3 nanograms per mil, and that means normal luteal progression. When they looked at gene expression profiles, anything above 5 nanograms per mil actually produced normal, indistinguishable luteal progression from the control group, no matter how high it is. In contrast, when you get out to 3 nanograms, you only get a partial response, and at 1.7, really just a tiny response. So that's what we think. We think that the threshold is somewhere around 3 nanograms in terms of starting to go, and maybe above 1.5, something is going on that may interfere. And some of you are probably using the 1.5 nanogram per mil value in deciding whether or not to freeze all of the embryos. That unfortunately goes beyond the scope of this particular talk. So now that we understand that the threshold is somewhere around 3 nanograms per mil, we can now look and see what happens in a natural cycle. When is it that 3 nanograms per mil are achieved? And you have to go way back, way back to find when people were doing these kinds of measurements. This is out of 1983, almost 40 years ago, from Sam Yen's group in San Diego. Here's LH. So LH surge starts where that line is present, and the FSH surge. And estradiol, as we all know, kind of dips around the time of ovulation. Look what happened to progesterone. So progesterone, these are picograms. So this is 1 nanogram right here, okay? So it's very low, very low. Now ovulation is going to happen, what, 24, 36 hours later? Right around here someplace is where the egg will leave the ovary. We're clearly below 3 nanograms per mil. In fact, 3 nanograms per mil, 3,000 picograms, only happens about 48 hours after the onset of the LH surge. So you're 12 to 24 hours after ovulation. 12 to 24 hours after ovulation. So at the moment that the egg leaves the ovary, there is no luteinization in the endometrium. So why are we giving progesterone in the morning of the egg retrieval when nature doesn't do that? Nature doesn't start really progesterone secretion until at least 12 hours later. So keep that in mind, okay? So natural cycles with an endogenous LH surge, progesterone is about 1 nanogram at ovulation, and 3 nanogram is 12 to 24 hours after ovulation. What about if you trigger with HCG? You say, well, I'm doing my frozen transfers now and I'm triggering with HCG. So the best study to look at is to look at natural IVF cycles. And we did a lot of natural IVF cycles back in the day. And this was our progesterone levels in an unstimulated cycle on the day of HCG. That means before you give it, obviously the progesterone is low. But even at the moment of follicle aspiration, there is no increase. This is different from hyperstimulated cycles, and I'll show you that in a minute, because the argument that I'm going to make is how much advanced the endometrium is in a stimulated cycle. Okay, so natural cycle with HCG trigger, very low at the time of retrieval or the time of ovulation, and likely a similar rise of progesterone over the next 12 to 24 hours. So are you doing natural cycles for frozen transfer, whether you're triggering them naturally or HCG trigger, you'll have the similar kind of rise, okay? So progesterone below luteinization threshold at ovulation, and then the luteinization progression then happens with a gradual endometrial progression between 12 to 24 hours, and then above the threshold at 24 hours. So if you look at the window of implantation, that's what we're talking about. It happens somewhere over in here. Begins cycle day 19 to 20, probably lasts about 4 to 5 days. So routes of progesterone administration, I wasn't going to talk about it, but then I felt I had to at least say a little bit. Just remember that you're giving a lot more progesterone than estradiol, and the oral route is prohibitive. The metabolism is just very bad. So is transdermal. In case you're wondering why it is that we don't have progesterone patches, they would have to be huge. So really all we have is intramuscular or vaginal. You all know that there's a uterine first pass effect of progesterone being absorbed out of the vagina and going directly into the endometrial tissue. And that is what this study from Ciccinelli shows. It's done very nicely. These are the serum progesterone levels, and serum progesterone levels are much higher with intramuscular progesterone than they are with vaginal. On the other hand, if you take the tissue out of the uterus and you look at progesterone content, it's much higher with vaginal than it is with intramuscular. So even though you get unpredictable serum levels, the tissue levels are very good. And here's a Cochrane review, and basically the conclusion from all of this is that there is no benefit of IM over vaginal or vice versa. If anything, there appeared to be kind of a trend in this particular review in any event towards vaginal over intramuscular, and specifically looking at the live birth rate, again, appears to favor vaginal, but not statistically significantly different. So you can do both. And that for that reason, I used vaginal progesterone for a very long time until this study came out that torpedoed us. And some of you are familiar with it. It came out in Fertility Sterility in 2018. They had 3 different arms. The one arm, the C arm, was only vaginal, and these were either intramuscular or intramuscular once every 3 days and vaginal the rest of the time. So intramuscular, once every 3 days and vaginal, and this is vaginal by itself. And the implantation rates, I would point out, are the same. This is a positive HCG, no difference. The problem is that they had a tremendous increase in pregnancy losses in group number 3. I'm not sure I believe that, to be honest with you. I shouldn't say that I don't believe the data, but I don't believe that that is an effect of the vaginal progesterone. But in any event, it skewed the data in such a way that the overall live birth rate, ongoing pregnancy, was much higher in groups A and B than it is in group C. And so this is kind of the end of using vaginal only. And I must admit that we now are using intramuscular, at least at the beginning, so that I don't have to deal with this kind of data, even though I'm a non-believer, and I switch them back to vaginal as quickly as I can. So I told you I was going to make the argument that the window of implantation is wide, and the experiment that I use for that is the consideration of stimulated IVF cycles with a fresh embryo transfer. I hope some of you are still doing that. I'm doing it. I think that the data are pretty clear that except in extreme cases with PCOS or patients who have elevated progesterone, there's absolutely no reason not to do a fresh embryo transfer. But you have to realize how much displaced the window of implantation is in a stimulated cycle. So the question is, when does progesterone rise in a stimulated cycle? And here's that same table that I showed you. Now, mind you, this is again 23 years ago. But look at the progesterone level at the time of egg retrieval. In a stimulated cycle, it's 8.5. And you all know it because if you're doing agonist trigger, if you're doing Lupron trigger or using any other GnRH agonist, you know you're measuring serum progesterone 12 hours after you give the trigger to make sure that it worked. And you know that progesterone is elevated. And now you know that the progesterone is not elevated in a natural cycle. So you know that it's at least 24 hours. And in fact, since luteinization doesn't take place until after ovulation in a natural cycle, it's even further. So the bottom line is, and that's what I'm trying to say here in this particular slide, remember, natural cycle doesn't start ovulating until 12 to 24 hours after ovulation, but in a stimulated cycle, the progesterone is elevated at least 24 hours before ovulation, and therefore 36 to 48 hours advance. So if the window of implantation were narrow and you moved it over by 36 or 48 hours, which is what the ERA people try to tell you, then you would have no implantations at all. but that is not the case, right? You all know that from this New England Journal of Medicine article that the live birth rate did not differ significantly between frozen embryo group and the fresh embryo group. Relative risk was the same. There were also no significant between group differences of rates of implantation, clinical pregnancy, overall pregnancy loss, and ongoing pregnancy. This is in women that do not have PCOS. It was only the PCOS group where there was a difference. So how wide is the window of implantation? Well, if you have the same pregnancy rates in stimulated and frozen cycle, and the same woman can conceive in both a fresh and a frozen cycle, that's very important, because I've heard the ERA people say, oh, the window is that wide, but on a personal basis, it's only about 12 hours wide. No, if that were true, then the same person could not get pregnant in a fresh and a frozen cycle. And in stimulated cycles, the progesterone is advanced by 48 hours. Then the window of implantation must be advanced by 48 hours. And therefore, the window of implantation is at least that wide. There's other problems with endometrial receptivity. So the response to progesterone depends on progesterone receptors, which are induced by estradiol stimulation. And estradiol stimulation is variable because of the dose, duration, absorption, and response to estradiol. And it is unclear to me, I will tell you, whether endometrial thickness is an adequate evaluation of the adequacy of E2 priming. I think it's not a bad endpoint. We use it. I have to tell you, I use it clinically. I keep in the back of my mind that we don't know that. And the ERA is based entirely on the fact that the endometrium has to be at least 7. The other problem with the ERA is that the evaluation of the endometrium, I think, depends on the location. The entire endometrium does not move at exactly the same pace. It is not, every cell is not exactly the same. And you will have areas that are further advanced and less advanced. That was a whole problem with histology. The same thing is, of course, happening biochemically. And a large sample will have different sections. So this was the false invalidation of histology. In case you're wondering whether I like histology, yes, I think histology does not lie. I think what does lie is our assumption that it is not correct. So I will just touch on this because it always comes up in the Q&A, and I'm not sure I'm going to have time to stick around, but you know that endometrial preparation for frozen thawed embryos have now been suggested to be associated with an altered risk of hypertensive disorders of pregnancy. And so the idea is that if we do natural cycles, that we're going to have, that we're going to eliminate this. And this is the study from Human Reproduction. It says crude and adjusted odds ratio of hormone replacement cycle against natural ovulatory cycle for obstetrical outcomes. And you see the statistically significant increase in hypertensive disorders of pregnancy and placenta accreta. Hard to understand what placenta accreta would have to do with it, to be honest with you. And here's another study out of hypertension saying increased preeclampsia risk and reduced aortic compliance with in vitro fertilization cycles in the absence of a corpus luteum. This is very interesting. It has biological plausibility. We're all intrigued, and I know that they're doing the studies. So stay tuned. Between just all of us, I'm skeptical, but I am perfectly happy to be educated and to be wrong. So very quickly, endometrial receptivity. What we have been talking about, it is a state of permissiveness to embryo implantation. It depends on adequate estradiol priming and adequate and timely progesterone stimulation. Luteinization begins 12 to 24 hours after ovulation. Now, if you're wondering when to start progesterone at home, how about 12 to 24 hours after theoretical ovulation or egg retrieval would have taken place, right? That's when progesterone levels exceed the threshold of 3 nanograms per mil. How wide is it? At least 48 hours. I think it's more like 3 to 4 days. So how do you achieve, in a practical sense, adequate estradiol priming? I think oral administration is okay in a majority of cases. If that doesn't work, you can consider transdermal. A lot of my patients actually like transdermal, especially if someone's nauseous with the oral. Prolonged exposure is okay and may be beneficial. 4 or 5 weeks. I've got somebody right now, she was here 4 weeks, endometrium is still only 6 millimeters. Maybe adequate, but I'm going to wait until it gets to 7. So we just keep going on with that. And then timely progesterone administration. I started 12 hours after ovulation. So I started in the evening of egg retrieval. And you can go to the next morning if you want. Route of administration doesn't matter because of that one horrible study. We have to use intramuscular, but I use it sparingly. As you know, it's painful, leaves a big mark. I would say that for future considerations, the role of estradiol is really underappreciated. I think extended duration is underutilized, And because I see it all the time, they give 2 weeks, they say inadequate endometrium, they say, oh, it's not working. What are we going to do? Just have it go longer. Timing of progesterone stimulation. I think most programs that I see are using progesterone earlier than what occurs in a normal natural cycle. And the rate of rise of progesterone may be important. We are giving a step function. We're getting no progesterone and then suddenly very high levels. That may not be physiological. Physiologically, remember, progesterone rises kind of slowly. An evaluation of the endometrium, you have not heard the end of that yet. Size of the sample matters. Be skeptical of the ERA. I like penopods, but they're unreliable as well. Well, so that's the end of my talk. Let's see, I'm going to stop sharing my slides. I don't know whether we're going to try to do Q&A now. I'm happy to stick around a little bit. I'm going to have to get back.
This is a section of question and answer for the first two presentation of our professors. The first question for you, Professor Bedawi, uh, uh, do anatomical abnormality include T-shaped uterus?
Not to the best of my knowledge, nor there is evidence to support its treatment.
Okay. The second,
unless Richard has anything to add.
I do not, and in fact, it was, I mean, in the old era of DES, the DES uterus was a very interesting phenomenon, but that's really of historical interest. Only those patients are no longer in the reproductive age group. But I could talk for a long time on DES. That was a very interesting phenomenon.
another question for you, Dr. Bedawi. What antibiotics will you advise for chronic subclinical endometritis?
I used doxy for 3 months, and 3 weeks, and then biopsy them as a test of cure and see after the next cycle if they still carry with it. I can give a second course, which happened to me once actually, that I have to repeat the treatment. Otherwise, in some patients, I used Cipro. So that's mostly doxy is my preference.
Okay.
So you're a believer in chronic endometritis, and you believe that it has an infectious
well, I can tell you right away, actually. I see a lot of patients with recurrent pregnancy loss, and we did more than 1,000 biopsies, and we find it to be very, very rare, and we stopped doing routine biopsies on those patients. So we don't biopsy unless we see something in the endometrium at the time of the hysteroscopy that tells us that there is something wrong. So am I a believer? I don't think I am a full believer. I believe in what I see. So if I see some issues with the lining itself and the way it looks, that I can infer that there could be a process, then that may justify a biopsy in my books, but otherwise I don't routinely biopsy patients.
So I'll give you just a 30-second tirade on that. It's called chronic endometritis because they have lymphocytes and plasma cells. Those are normally present in the endometrium. We don't know that. And then the huge problem now that is also being marketed by an unnamed company that I hope is not a sponsor is this idea of the microbiome inside the endometrium, which is not, those are not cultures, that's DNA and little fragments of bacterial DNA. And they say, and this proves that the microbiome is associated with that. I would argue that that's the biome that's coming from the vagina being filtered through the cervical mucus, and you get little pieces of DNA and people are amplifying them and they're acting on all of this. This is all very preliminary and very hypothetical and not yet evidence-based. I think it's all very interesting. I love the endometrium, but I think we're going down a lot of rabbit holes that I think may distract us from where the real problems are.
Well, if I add only one thing, I said, I would say that definitely we did not see the 14% incidence that was reported in the fertility sterility article, not even 1%.
Yeah, right.
So,
yeah. The next question for Dr. Bedawi. What do you mean by subendometriotic hemorrhage and how to avoid it?
well, again, that takes me to the same discussion of a controversial topic. It's basically when you see the endometrium not looking the same homogeneity all over the entire perimeter when you do a hysteroscopy, provided that you're not causing this with your scope itself or not hitting the lining. And it's probably an endometrium that has to be looked at, and that's probably one of the few instances that I consider doing a biopsy and sending it for examination.
Okay, I think there is this question for Dr. Bedawi and also Dr. Paulson. Dr. Yaoub can share answering it. In case of adenomyosis, what is the best plan you will do for your patient?
I would be interested to hear Richard, so I wouldn't cross my lines, and then I would comment after him.
I have had so the simple answer is that I think that adenomyosis does not adversely impact embryo implantation. But that is an oversimplified answer. But we looked at many instances. We looked at egg donation recipients who were older and had a fairly high incidence of adenomyosis, and it did not seem to make any difference. I know that the old series from Tony Policer and Carlos Simon also did not find anything. I had an extreme case of a patient who had adenomyosis up to her umbilicus, and I really recommended that she have gestational surrogacy. She wanted me to transfer the embryo, and she became pregnant, and the adenomyoma stayed over to one side while the uterus rose. So I don't do anything with adenomyosis. We've had patients who were down-regulated on with GnRH agonists to shrink the uterus down. As you know, it grows back fairly quickly. So so that's all the wisdom I have. I don't think it makes a difference. It must, but whatever impact it has must be relatively low. That's my impression.
Well, if I may add few things to here, actually, I see quite a bit of adenomyosis patients that are referred for a variety of reasons, particularly in the context of recurrent implantation failure. What I noticed from managing some of those patients is there is the cavity distorting adenomyosis. So I've seen a lot of patients, actually, because again, we're a tertiary referral center, where you can see the adenomyosis is pushing the posterior wall of the uterus, specifically the posterior wall, mimicking a picture of a submucosal fibroid. And the extent of the disease on those patients, sometimes we have the data from the meta-analysis that was published by the Italian group that says it affects the ongoing pregnancy rate and IVF if you have diffuse adenomyosis. And we have the paper from Dr. Khalaf, so he wouldn't escape contributing to this question, that if you have at least 4 of the 8 signs of adenomyosis by ultrasound, it's likely to impact the outcome of IVF negatively. So that is the subcategory of adenomyosis that I consider looking more carefully before continuing to waste valuable embryos, transferring them into this uterus, and the patient would not get pregnant, particularly in patients who are not going to have any further IVF cycles, and I know that they may not get pregnant on their own because of other issues. So in these situations,
do you fix the uterus? You fix the uterus?
Well, I'm coming to that, actually. So the way I counsel those patients, if they have like 3-4 good embryos, I say exactly what you said. Go ahead, let's transfer 1 and 2, or 2 even, and see what happens. And if it's a good quality embryo, I know you're not a believer in PGTA, but if they are PGTA tested also and they don't take, then I have a very long discussion with the patient, and I offer them 2 options. Either prolonged downregulation with Lupron for some time, and that's the only thing I offer if they have diffuse adeno involving the entire uterus, or considering adenomyomectomy if they have a focal disease. And I have like an N of 20 probably adenomyomectomies that I did over 5 to 7 years period. And actually the majority of those patients conceived and carried to term. One of them I attended our C-section on purpose to see how the uterus looks like, and it looked fine. So there could be a role for adenomyomectomy, but we have to be very selective in what type of patients we should subject to this huge surgery.
I don't have a lot to add, really. Surgery for adenomyosis, as far as my experience is concerned, is rarely satisfactory, because in order to remove every adenomyosis there is, probably you will end up removing the endometrium in the process. So it is always something that's incomplete, whether it give you the benefit that you are hoping for or not. It can give symptomatic relief, but as far as reproduction is concerned, really little is known or is in the literature to suggest that one intervention will lead to better outcome than other.
Next question for Dr. Bedawi. What is the best for uterine septum resection? To use monopolar or bipolar?
Well, cold scissor if possible. Actually, that's what my preference is, unless it's really very, very, very thick and muscular one that will bleed and I wouldn't be able to complete. So my default technique is cold scissor, the way I do the Ashermans.
Okay. Next question for you also. What is the role of hyaluronic acid gel in the prevention of intrauterine adhesion after septum resection and after the treatment of Asherman syndrome?
I personally have no experience with it. There are some data there. I don't think it adds that much, but the jury is out. If we have a good study that shows it works, we'll be happy to look at it.
Okay. Some question for Dr. Paulson. What about endometrial compaction and its relation to implantation? This question from Dr. Abdulaziz Hasaballah.
Yeah, that's been suggested now newly that we should be looking at how much the endometrium actually compacts. I'm not currently using it. I think it's an interesting concept. I certainly would not be using it clinically at this point in time. I think it's interesting data that we should collect, but I've seen too many other variables, and I'm not. I don't know. I'm aware of the data. I think it's not definitive. Don't use it clinically at the present time, and let's see how it goes.
Okay. Another question from Dr. Ahmad Badruddin. Do we understand that subcutaneous progesterone is disappointing compared to intramuscular or vaginal?
Yeah, we don't have that in the United States, unfortunately, but I see no reason for why that would be any different. So the great thing is that if it's given by any kind of injection, any kind of parenteral route, then the serum levels will be reflective of what's happening physiologically, and therefore I see no reason that the subQ would be any different from IM. That's perfectly okay. It's not metabolized any differently. I think it's very promising, actually. I think it's going to be a great product for us.
We have been using the subcut progesterone for years now. We took part in the original study that compared it with vaginal progesterone, and the outcome is similar. So it provides a good alternative to vaginal when it is not particularly liked by patient, and it is also a less taxing parenteral injection compared with the deep intramuscular injection, which, as I always tell my patient, literally pain in the butt.
Okay.
Excuse me, Professor Yaqub, the pharmacodynamics for the subcutaneous injection of progesterone is a little bit different compared to the intramuscular. I can remember that the level of progesterone after subcutaneous is very high for the like 4 hours something, then goes down very rapidly to a very low level. So do you use multiple injections per day, or what?
25 milligram aqueous solution subcutaneously. If a
Only
patient,
one.
if a patient has high BMI, you would venture either to add vaginal progesterone as 400 milligram, or you give the patient a couple of injections. But I think that would be overkill.
Another question from Dr. Rifat for Dr. Paulson. Any significant rule for endometrial platelet-rich plasma?
Endometrial what? I'm sorry.
Any rule for endometrial platelet-rich plasma?
Platelet-rich plasma? Oh,
yeah.
Okay. That is. Please tell me you're not doing it. I would just say, please tell me that you have not fallen for this latest snake oil, please.
You are just too polite, Dr. Paulson, because I describe it straight away as fake news.
Okay.
Another question from Dr. Muhammad Deep for Dr. Paulson. What is the maximum dose of estradiol, and is it affected by body mass index in case of frozen embryo transfer?
You mean oral or transdermal?
Oral.
Well, I mean, I don't know that you would want to go higher than about 8 milligrams. I mean, you're metabolizing it. Remember that vaginal estradiol is absorbed very quickly, very well out of the vagina, and also is selectively taken up by the endometrium. So if you just can't get it to absorb after oral administration, I would go to a different route. That's not a very efficient route of giving it. It's a good first line because it's easy for women to take the pills and so on, and it works in the majority of patients. But if you really are having an issue with somebody taking it you still have all of the problems with hepatic globulin production and so on. So if you think somebody has a very high BMI and you're worried about that, maybe start transdermal and then go vaginal rather than oral.
Okay, another question is when to stop estrogen and progesterone in artificial cycle of frozen embryo transfer?
Yes, there's lots of studies that show that you can stop a lot earlier than most people do. There's also probably no harm in continuing it. So I don't know that we're ever going to get the correct answer. It's probably okay to go through the first trimester if you want, or 10 weeks. And now I've seen lots of studies where they stop at the moment of the heartbeat. I think it's really, I wish I had more data to tell you. I'm embarrassed to tell you that we give it for longer than is necessary. But it's not necessary. You can stop early.
Okay, there is a shared question for Dr. Bidewi and Dr. Paulson. What is the role of stem cell treatment to improve endometrial receptivity in repeat implantation failure cycle?
Well, no data.
What
to
is
the best of my knowledge. So I think Dr. Paulson already insinuated that when he talked about Carlos Simon work for Asherman syndrome and stem cells to regenerate the endometrium. But I don't think there is anything in that direction that we should be really kind of thinking that it would work. I don't think there is anything in that direction.
It should be done under IRB, and I was so excited when they started doing it because it looked so promising. It was such a logical thing to do. You're missing the stem cells. We're going to give back the stem cells. This should work. And they showed very definitively that it stays around for 1 month, and by the end of 2 or 3 months already it is gone. So we have not yet solved that riddle. It's very logical, and people, we should be pursuing it, but right now only under research protocol.
But what is confounding about using stem cell is that they use it for Asherman. So they do the surgical correction and then they put the stem cell. So you don't know which one, even if it works. Is it the surgical correction or the snake oil that you have just put in? So you really don't know.
So what's interesting is that women who get stem cell transplant for leukemia will then be found to have, as you know, the donor cells actually make their way into the endometrium. And when you do an endometrial biopsy, you can identify the genome of the donor who donated bone marrow, let's say 20 years ago, which I find fascinating. And so, again, a good rationale for why the stem cells would work in the endometrium. But unfortunately, again, like I said, the Asherman is a terrible disease. It's the endometrium commits suicide, and no matter, so far we have not yet solved figuring out how to resurrect it.
Another question from Dr. Potros Rizk to Dr. Paulson and Dr. Bidewi, Dr. Yaqub. I think part of them will be covered in the next presentation of Dr. Yaqub. What is the preferred protocol for frozen embryo transfer? This is the first part. The second part, do you use estradiol and progesterone from the beginning of the cycle? And do you insist on trilaminar endometrium before progesterone start?
Well, you start estrogen at the beginning of the cycle. You start progesterone only after you have adequate endometrium. The endometrial thickness that we all chase is 7 millimeters, and it generally is trilaminar at that point. If it is not, remember that a lot of it is ultrasound artifact as to the position of the uterus. You have to be very careful about that. The angle of the ultrasound versus the angle of the endometrium will make a big difference in the appearance. So I don't put much stock into that. Artificial cycle means estrogen at the beginning and then estrogen and progesterone in the second half of the cycle.
For day 3 embryo transfer, when you start progesterone, and how many days in a frozen transfer? How many days in frozen transfer the hormonal replacement therapy will continue?
Yeah, this is the same question. Maybe we should go around the group and see what everybody does. I start progesterone 12 hours after the estimated time of ovulation. So I will transfer a day 3 embryo on the 4th day of progesterone, but I start progesterone in the evening. So on Monday, I'll start the progesterone in the evening, Monday, Tuesday, Wednesday, and on Thursday in the morning, I will do the transfer. So you will say, well, that's only 36 hours. Yes, that's correct. On the fourth day, with the progesterone starting 12 hours later. So what about everyone in the group? You guys start
We
earlier?
have
Or?
very much the same protocol.
Yeah, okay.
Dr. Atiaf asking, what is the better protocol for frozen embryo transfer? Either natural, stimulated, or modified natural?
Now, there are lots of prospective randomized trials have showed that there's no difference between any of those in terms of the probability of outcome. And what I was saying at the end is that the corpus luteum, whether that's going to make a difference or not, that has not yet panned out. But you can do all of those. I will tell you that the natural cycles are they're a lot of work. There's a lot of monitoring. The artificial cycle has a tremendous advantage that you don't have to monitor them so much. The natural cycles are kind of the same, but all of those work the same. That's my impression. And anyone else? Mohammed, what do you do?
Well, mainly for scheduling purposes, it's almost entirely artificial cycles.
Yeah, right.
Another point from Dr. Hazem Abdul Ghaffar. What to do with persistently thin endometrium with no evidence of adhesion by hysteroscopy? This is for Dr. Paulson and for Dr. Bidewi.
Yes, well, like I said, long and slow. 1 or 2 patches, adjust the serum estradiol level to between 100 and 200 picograms per ml, or somewhere, let's say, around 200, and then go for a long time. Go for a long time to stimulate the endometrium. And like I said, all PCO patients have thick endometrium. So if you give unopposed estrogen long enough, you're going to get a thick endometrium. I think that's how that works. And remember that endometrial thickness is only our interpretation of what's happening physiologically. The imaging is imperfect. If you cannot get the endometrium thick enough, I think it's worth reassuring yourself with a biopsy that the patient has luteinized, and I think you can do an embryo transfer. You don't necessarily have to get to 7 millimeters in every case before you do the transfer.
If I add anything to that, I definitely support everything you said. But if you look into the data that was published from the Canadian group in human reproduction about the endometrial thickness, you still get decent pregnancies even below 7 millimeters. So if that's all you got after prolonged treatment, that's the way the endometrium is behaving, and probably you should go ahead and think about transfer at that.
That's very important. I mean, I have seen patients who are referred for gestational surrogacy because their endometrium doesn't make it to 7 millimeters. So that's not evidence-based. Some women will simply not get a thick endometrium.
Another point. Yeah.
So the time, look at the time.
Yeah, exactly.
It's
noon now. I think Mohammed,
we're having fun.
Yes, the last one. In the frozen embryo transfer, do you use from Dr. Potros also? Do you use 120 or 144 or 168 hours of progesterone before embryo transfer?
For blastocyst, you mean?
Yeah.
So I start in the evening and I transfer on the 6th day of progesterone. So it's 5 times 24. 120 hours. Final answer.
Thank you very much for this nice discussion.
It's great. It's great seeing all of you.
Yeah, thank you very much. This is to prepare for our next speaker, Professor Yaqub Khalaf. Professor Yaqub Khalaf is a professor.
Please keep it short and please. Thank you.
Dr. Yaqub is also from Upper Egypt. He is born 100 miles north to the place of I'm speaking from now, and he is earned his undergraduate 50 miles in Asyut University. Dr. Yaqub paved his way to north into UK, at which he is serving as a professor of reproductive medicine and surgery at St. Thomas Hospital. Dr. Yaqub also is now appointed as the head of the fertility service and director of assist conception unit. He is a member of the Human Fertilization and Embryology Authority and act as a chair of the Scientific and Clinical Advisory Committee.
He's speaking on frozen embryo transfer
Yeah,
or luteal
he
phase.
published more than 160
Muhammad.
publication in most of them in the elite journal like New England Journal of Medicine, The Lancet, and Nature. And actually, I mentioned 3 lines out of 3 pages of his generous and inspiring biography. Dr. Yaqub is co-president of Upper Egypt Assisted Reproduction Conference. Thank you, Dr. Yaqub, for presenting the forthcoming presentation on luteal phase management in frozen embryo transfer, current practice and future opportunities.
Thank you very much.
Yours.
It is really great fun to be speaking after Professor Bedawi and Professor Bolson. And I have to confess that I am, what is the word? I'm guilty of saying yes without knowing the question. Because Muhammad Sabri said, oh, do you mind participating in the next webinar that will be talking about luteal phase and frozen embryo replacement and preparing the endometrium? And I said yes, without knowing the division of labor. Little did I know that the first 2 speakers, particularly Richard Paulson, will speak about everything to do with embryo transfer after preparation for frozen cycle. As if this is not enough, we had also the question and answer in the middle, which completely killed off anything that I have to say. But I will try to go around the edges, if you like. If you read the Ahead of Press publication in Fertility Sterility website, you will find a very interesting views and reviews papers talking about some key performance indicator for the clinical side and for the lab side. And what caught my eye is the 3 simple metrics to define in vitro fertilization success, written by Kat Fisher and Richard Scott. And these are the clinical simple metrics that effectively describe clinical outcome from ART treatment. The first one is the probability of having no embryos for transfer, because that really captures in one all the failures prior to actual embryo transfer and whether they are explained or they are contributed to by some incompetencies. The second one is a sustained embryo implantation rate. You put the embryo back, how many of them will lead to a live birth? That's also a good reflection of the environment and the handling and the selection and whatever you have done. And the third one is how efficient you are with your stimulation, judging by the number of supernumerary embryos per treatment cycle, which will give you more or give your patient another lifeline or 2 with the use of frozen embryos. And this is the link, using surplus embryos to use in subsequent frozen embryo transfer cycle and try to get it right. Now, all of that is being covered, but it is no harm going back over them again. How you prepare your frozen embryo transfer is really not the major issue. Whichever preparation you use, whether it is the natural or the medicated, whether it's down-regulated or without down-regulation, it really doesn't matter. And the methodology for achieving estrogen and progesterone level adequate for implantation can be quite variable, but they are all the same. The bit that usually captures the imagination of the clinician is the thickness of the endometrium. And I came across this article, as always, from anything and everything with big number appear to be more convincing and gives you a true reflection of what happened. These papers happen to be from Canada, and you can see here that the vast majority of patients will have that magical limit of 8 millimeter or thicker endometrium. So no problem here. And the outcome will be hopefully proportionate to that kind of what we're looking for. The live birth rate is 34%, and 7 to 7.9 millimeter, still respectable number, and it is encountered in 8%. So we finished the best part of 95%. So all what we kill ourselves about with controversy about thin endometrium, we're talking about maximum of 5%. Whenever you speak about this subject, you find all the discussion about what do you do about thin endometrium. You will be forgiven to think that is the rule rather than the exception. But just let me remind you, these are rarities, thank goodness for that. And here with 6 to 6.9, the live birth rate is 25%. It's not dissimilar from 7 to 7.9. And here from 5 to 5.9, it becomes a little bit less convincing, but equally it is less number. When it comes to 4 to under 5 millimeter, it is limited number. And therefore, it doesn't make sense to try to look for pregnancies in terms of live births. It is not there, not because it didn't happen, but probably because a small number. And under 4 millimeter, there doesn't seem to have been any clinical pregnancy in this series. So it gets very bleak with extremely thin endometrium. And as I said, look at the incidence is 1.1%, which is effectively 1 in 1,000. So if you do 500 frozen embryo transfer in a year, it will take you 2 years to come across this very perplexing and complex situation. When you use day 5 transfer for the previous one with day 3, you look at the same. 8 or more, you're talking about here 30% live birth, 29%, 7 to 7.9, 26%, 6 to 6.9. And when it comes to 4 to 4.9, you're still getting pregnancies in a decent number. And luckily in this series, there wasn't anything under 4. So the clinical pregnancy rate and live birth rate decrease for each millimeter of endometrial thickness below 8 millimeter in fresh cycle and below 7 millimeter for frozen embryo transfer cycle, which you could have figured out. It's always nice to see an endometrium that is making the grade. Viable pregnancy rates remain reasonably acceptable in patients with an endometrial thickness between 4 and 6 millimeter, as I have just shown you. So, what is the optimal endometrial preparation for frozen embryo transfer of screened embryos? In case the endometrial, the follicular phase has extended. I know Richard covered this comprehensively and as an authority, and it is our experience too, but it is good to have it kind. This is an abstract that was submitted to one of the ASRM in 2015. And look here, for the duration of the follicular or estrogen, 13 days to 23 days. Doesn't seem to be making any difference to those euploid blastocysts being replaced. The implantation rate, still it is magnificent. So don't get excited about having to start the progesterone, as Richard highlighted, once you hit 12 days, because it is not a time bomb. It will wait until you get the desired objective, and not just that, until it gives you the flexibility of scheduling, and that is the beauty of using estradiol prepared endometrium. The optimal endometrium preparation of frozen embryo transfer of screened embryos is independent of the follicular phase, and that is the bottom line from that previous presentation. No impact on implantation rate in the context of number of days of estradiol administration. From our own experience, we use estradiol up to 35 days, and the literature also confirmed that. So, the timing and duration of the so-called window of implantation remains unclear, although it is thought to last from 2 to 4 days, opening and closing in the midluteal phase. This statement was made in New England Journal of Medicine 20 years ago. I don't think a lot has changed since. It is still not clear, and I hope you will see how. Here there is a paper published in Journal of Assisted Reproduction and Genetics in 2018, talking about does endometrial receptivity array or the ERA test really provide personalized embryo transfer? You will be surprised that some colleagues in Egypt are fond of endometrial receptivity assay, and they send the result, the biopsy to Valencia or somewhere else, and patient pays through the nose, and assuming that it will give them an acid test. Unfortunately, the results is far from this, and most of the time is disappointing. Here is that reported series of 53 ERA testing and 503 without, exactly like what we do, without that bit of sophisticated, expensive, and not well validated test. The outcome of ongoing pregnancy rate after correcting by the ERA test result in this group is 39%. For that huge number, without ERA test, without the extra expenditure, without the extra excitement, is 35.2, and as you can expect, the difference is non-significant. Now, let me tell you my experience with ERA test. Not that I have ever asked my patient to have it, but we had that discussion with Carlos Simon, who is a first-class scientist. But unfortunately, being a first-class scientist does not mean that you have a good grasp of how evidence can properly assess. Carlos Simon, he was marketing the test, and he claimed to be doing a randomized control trial. This is contradiction in terms. The whole essence of doing a randomized control trial is that you are genuinely at equipoise. You don't know whether this intervention helps or it doesn't. Conversely, if you market something, then you are absolutely certain that the money you get from the patient, you are giving them added value for what you offer. So the two can't go together. You're either confident it doesn't need the randomized control trial, or not confident you can't market it. But to have the two together invalidate whatever message that come out from this result. So the results of the present study do not support the use of ERA test in a mock cycle prior to FAT as a way to improve pregnancy outcomes in good prognosis. And also the thesis that Carlos Simon, probably for good reason, he suggests that the implantation window, if you do ERA test over 40 consecutive cycles, it will be consistent. That is just not consistent with the biology as we know it, because we see from cycle to cycle, you could have a 29-day cycle or a 27-day cycle, and ovulation is perfect in both cases, and you would not expect the implantation window or the timing not to be affected by this one plus or minus day. The other interesting vogue or motion that is currently happening in frozen embryo transfer or arena is measuring serum progesterone on the day of frozen embryo transfer. And you would ask yourself, any added value? Probably this is the only aspect that I didn't hear Richard quite digging deeper into it, and we can have a discussion afterward. Elizabeth Labarta from Spain have been interested in this and suggested that there is a cutoff point of progesterone below which really the outcome is not great, and you should consider abandoning embryo transfer, and you should not put the embryos back. And she reads this cutoff, and if you read the correspondence that followed that paper, you'll feel that there was doubt about the validity of using those kind of arbitrary figures. But her result from that limited number, look at here, 52, 53, 53, 53, it is not good enough to come up with a cutoff point that is categorical. Under 9.2 nanomole per mil, the implantation rate here, she suggests that it is lower. The clinical pregnancy rate is not great. The ongoing pregnancy rate here is 33, but in other groups, it is 51. So she reached a conclusion that with this, I'm sure many people will take this 33 with open arms and it's not worthy of canceling the cycle. Here, when it is in the third quartile, you're talking about 59%, here is 51%, and here is 49%. However, this is the conclusion of the paper. The first prospective study to find a correlation between serum progesterone level on the day of embryo transfer and ongoing pregnancy rate. You may find from, you'll remember from my last presentation in the series of webinar that we remind ourselves that correlation does not always mean causation, and you can correlate anything with anything if you use the right statistics. The results suggest a minimum serum progesterone threshold to optimize ongoing pregnancy rate and artificial cycle when using intravaginal progesterone. This finding, if confirmed, at least there is some humility here and some doubt, should be considered when deciding if embryo transfer should be postponed or not according to serum P level. We have not seen any confirmation, and this is the conclusion. But interestingly, in this year, a couple of months ago, there was a paper published talking about the very same subject. Do serum progesterone levels on day of embryo transfer influence pregnancy outcome in artificial frozen sow cycle? But before reading this paper, you would think that it is dangerous exercise to ever use a single point measurement to make black and white of biology that always know ranges and very seldom knows a single cutoff. So whenever someone said 9.2 or 1.5 in case of raised progesterone in the late follicular phase, you should always have doubt because biology is not that precise. It just has a lot of flexibility. So in this paper that is from Australia, here is 807 cycle with progesterone under 10 and 1200 cycle with progesterone 10 or more. And they compared every parameter or confounding variable to demonstrate that the two groups were comparable with all the factors that affect the outcome. And look here at the biochemical pregnancy is not significantly different, whether it is above or below. Clinical pregnancy is not significantly different, whether it is above or below. Live birth, it is not significantly different, whether it is below 10 or above. They had to move the goalpost and use 20 nanogram per ml. Again, there is no difference between below or above with biochemical pregnancy, clinical pregnancy, or live birth. They had to go back lower, and they went for under 5 nanogram per ml. And biochemical pregnancy was not different, clinical pregnancy was not different, and it's only live birth that was different. It's almost half. And I would not take this on its face value. I would probably try to dig deeper, whether it is a question of sample size, it's a question of other parameters that were not accounted for in this group of patients. But if it is corrected, at least it is acceptable because it is at the extremely low level of progesterone, and you wonder why in this particular group of patients they had that very low level, whether it's a bioavailability issue, whether it's a route of administration issue, whether it's a BMI, whether it is whatever. So it needs further exploration. They did all their adjusted multivariate analysis, and they could demonstrate only in the live births when the progesterone was equal or under 5 nanogram per ml, the success rate was significantly different in terms of the outcome. Now, moving on to the issue that's been discussed repeatedly, how to prepare the endometrium for frozen cycle. And we have natural cycle and we have modified natural cycle. And in simple terms, if your patient is alert and can measure the LH surge in urine through using the ovulation detection kit, where she could do the measurement even twice a day at certain time from day 10 of a 28-day cycle, for instance, fine, you can use that. But if you have doubt about وعي المواطن بتاعك excuse me, if you're not sure that the patient will appreciate this, then you can use the modified natural, where you measure the leading follicles on day 10 or 11, and when it reaches 17, 18 millimeter, you can give the patient HCG, and you can time your embryo transfer as if that HCG that you gave is equivalent to the LH surge that you were looking for. And effectively, it's 7 days from the day of HCG or 7 days from the day of surge. So if a patient had a surge on Thursday, she will have her embryo transfer on Wednesday next week. If the patient was given the HCG on Thursday, she will have her embryo transfer on Wednesday next week. So that's the natural or modified natural. How about the prepared cycle? From day 2 of the cycle, because you don't usually capture them on day 1, unless if you give the patient the medication ahead of schedule, then she can start on day 1 or day 2, it doesn't really matter. And she can use oral or transdermal, whichever is preferred by the patient. Some patients will have nausea and will have a bit of sickness from the estradiol orally, so transdermal estradiol is great. And then you ask the patient to come anytime between day 10 to day 13 of estradiol, and if the endometrium measure above 7 millimeter, you have a choice to start progesterone. But if your patient is not available on day 6 after starting progesterone, then you can push it for when she is available. If you also have some commitment like a meeting or thing, and you would like to be there for the patient, moving it by few days will not rock the boat. It will be absolutely fine. You can use vaginal progesterone, you can use rectal progesterone, you can use intramuscular or subcutaneous progesterone. They all do the same job. And this is what is winning the race currently, this regime, as far as the artificial cycle is concerned. But previously, we used to indulge in using GnRH agonists to suppress the cycle before starting estradiol, just like the long protocol in stimulation, except instead of stimulation, we were giving estradiol. Or some people started using antagonists for the first 7 days of the cycle with estradiol. I still find the logic very interesting. We've never used it at our center. Richard has alluded to the fact that natural cycle embryo transfer, frozen embryo transfer, is being shown to have better safety maternal outcome in comparison with the artificial cycle. It is all to do with the availability of that magical structure called corpus luteum, because produce a lot of stuff, some of which we know, some of which we don't, but it appears to be good for the vascular endothelial integrity on the maternal side. What type of progesterone to use? We agreed that the formulation, intramuscular, vaginal, subcutaneous, rectal, whichever, really, it doesn't make any difference. But let's just remember one thing. Using natural progesterone is probably the safest option, because currently there is an introduction of synthetic progesterone like dydrogesterone or dofastone, and we had to rebuttal this and urge caution by a letter or correspondence with British Journal of Obs and Gynae that's currently in press. And our thesis is using steroid hormone in the first trimester of pregnancy is a serious issue, because organogenesis takes place at this time, and therefore there is a possibility of harm, not only from congenital anomalies, but also long-term and even intergenerational effect. Anyone investigating the use of steroid hormone in the first trimester should remember the DAS legacy that it's been mentioned already, and it caused devastating harm. There is evidence that there is potential harm from dydrogesterone, particularly congenital heart disease. This is being demonstrated that the odds ratio is nearly 3 times the risk of congenital heart disease after using dofastone. It is not concrete science. It is open to question, but at least it sends the alarm bell ringing. Some of us may not appreciate that this progesterone that we talk about it as a cheap and harmless and available medication is really not worthy of even respect. But few of us know that the introduction to the world of progesterone through conversion of pregnanediol was worthy of winning Nobel Prize by this German scientist in 1939. And as much as he was lucky to get the Nobel Prize in 1939, but it was the first time to have a raging war in Europe, that meant that he did not get that prize, and he had to wait 10 years to receive this prize in 1949. And why I mention that? It is just to get you aware of the structure. Natural progesterone that we all advocate has this chemical structure: 21 carbon, 30 hydrogen, 2 oxygen. Micronized progesterone is the same structure. But when it comes to dihydrogesterone, it is 21, but 28 hydrogen and 2 oxygen. 17 hydroxyprogesterone, it is having 1 extra oxygen. You would think there is little to separate the two. Yes, on the face of it, there is little to separate them in the terms of number of atoms. But if we take lesson from history, because here is estrogen, and here is diethylstilbestrol. It's only a difference of few hydrogen. Here, estrogen is C18H24 and 2 oxygen. C18 for diethylstilbestrol, the same, and 2 oxygen and 4 less hydrogen, that is 20. And we can all be reminded of the vast difference in terms of harm that happened to the offspring that resulting from that exposure. And this is the paper that we felt strongly. It could be alarmist, but we're just asking people to be cautious about using anything less than natural progesterone for the luteal phase support with IVF, or for any other reason that allows exposure during the first trimester. How long to use progesterone for luteal support? This is a question gets asked all the time. And even as recent as 2020, people have the appetite to do systematic review and meta-analysis, and one of the young clinical fellows were doing this meta-analysis with Tim Child in Oxford and Scott Nelson in Glasgow. And the bottom line is confirming what we all knew before, that it's probably possible to stop progesterone on the day of the positive test, because the pregnancy hormone, HCG, is a very good luteal supporter. But in order for us to feel better about ourselves, we go along, and some of us will be so radical to give it until 12 weeks, which totally and utterly unnecessary with fresh cycle. And some of us will stop at the first pregnancy scan, which is reasonable, and it confirms what National Institute for Healthcare Excellence in the UK has recommended. When it comes to the frozen embryo transfer, we all go for until 12 weeks, which is a little bit overcautious, but there's no harm. But if you stopped it by the end of the 10th week, probably it will be fine. So we know why we do what we do. Just I thought, because we use natural cycle increasingly now, and we use the HRT using just the estradiol with little down regulation. Here
Unmute your microphone, Professor Yaqub. Unmute your microphone.
the figures for a whole year from March directly from the HFO website. And you see in 1 month, we're nearly 50%. In 1 month, we're nearly 28%. But I just did the calculation for you, clinical pregnancy rate of 298 clinical pregnancy over 791 frozen embryo transfer. That does not include PGT at all. 38% clinical pregnancy rate. 83% of these frozen embryo transfer is just single blastocyst transfer. So the point is that the chances of success are reasonably good with just using either HRT or with natural or modified natural cycle. So in conclusion, for the bit that is kind of left over, what is left over, luteal phase understanding and management is becoming crucial because we are doing more and more frozen embryo transfer. Endometrial receptivity is important, but the window of implantation issue is still elusive. ERA test is academic, and it's interesting academic because it's always nice to talk about the gene expression that is upregulated and downregulated, and you get nice, colorful graphs. But the evidence is not particularly great. Measuring progesterone is of little practical application at this point in time. Natural progesterone use is preferable, and the practicalities of preparing the endometrium are a lot clearer. Either natural or modified natural or artificial using estradiol preparation is pretty straightforward, and it should not be made complicated by measuring hormones unnecessarily and by bringing the patient to have her endometrium checked from day 7 or day 8. Why? Why? Is it just an exercise of maintaining acquaintance with the patient? Practically speaking, you just need to bring her day 10 or day 11 or day 12. That should be enough. And I think that's what I have to say, and I thank you for your attention.
Now it is my pleasure and honor to present my colleague, Dr. Muhammad Sabri. Dr. Muhammad Sabri is a lecturer of Obstetrics and Gynecology Department in Suhaj Faculty of Medicine. Dr. Muhammad Sabri is attending Obstetrics and Gynecology surgeon, Suhaj University Hospital. He earned his medical degree in 1999 from South Valley University, Egypt. After completing his residency training, he earned his master's degree in obstetrics and gynecology in 2007 from Suhaj University. Dr. Sabri spent 3 years of fellowship training at Mehari Medical United States, during which he earned the Certificate of American Registry of Diagnostic Medical Sonography, and shared through his publication and presentation in many national and international meetings focusing in the area of ovarian biology, female infertility, as well as developing novel medical treatment and uterine fibroid. Dr. Sabri is also one of the co-organizers of Upper Egypt Reproduction Conference. Dr. Muhammad Sabri will present in his lecture the topic of frozen transfer, when and why. The microphone is yours, Dr. Muhammad Sabri.
Thank you, my friend, Dr. Fawzi. Actually, talking after giants is really difficult. And so that I prefer to sit on their shoulders before talking. My talk today is, we'll discuss the freezing embryos, when and why. I will cover the objectives of freezing and freeze-all policy, history behind freezing, why we do freezing, and clinical indication of that, and how we do freezing, and assumed benefits and possible downsides and risk of freezing embryos. Freezing and freeze-all policy is a freezing the entire cohort of embryos, not just the second best. And the best embryos are transferred in a later cycle into a more theoretically physiologic endometrium. It seems as a new and brilliant idea, aiming to prevent possible complications and emphasize probable benefits. The history behind freezing is a very, very long time back. It actually is Spallanzini published his drawing of spermatozoa freezing about 3 centuries past, and it takes about 300 years for the concept of elective cryopreservation of all available embryos to come back. Huge number of studies were published to cope the rising number of frozen embryo transfer cycles, which is increased by about 80% between 2006 and 2012 in US, and by about 30% between 2008 and 2010 globally. The question came to my mind, so why we do freezing? Actually, there are many concerns about increase in the uterine contractility in fresh cycle. This might lead to an increase in the risk of ectopic pregnancy when comparing fresh transfer to frozen embryo transfer. There are many concerns about the possible adverse effects of controlled ovarian stimulation over the endometrium, may be related to endometrial advancement, may be related to gene expression. As we know, more than 200 genes related to implantation expressed differently with controlled ovarian stimulation. Digging deep a little bit, proteomic profile of the endometrium treated with both gonadotropin-releasing hormone agonist and gonadotropin-releasing hormone antagonist showed upregulation of cytoskeleton and downregulation of energy metabolism proteome. The endometrial receptivity seemed to be affected by both gonadotropin-releasing hormone agonist and antagonist, but the selectivity for the antagonist effect is more. So the clinical indication of freezing may arise in cases with high-risk women for ovarian hyperstimulation syndrome, such as women with polycystic ovarian syndrome, cases with pre-implantation genetic testing for aneuploidy, patients with pre-ovulatory elevation in progesterone, however, it's a little bit doubtful, patients poor responders in such protocol like use them the whole embryo cohort use as if we want to use day 5 and day 6 embryos. Patient of which day 6 blastocyst with embryo endometrium asynchronization And such patients of which we encounter suddenly uterine polyp, adenomyosis, hydrosalpinx, and any other endometrial or myometrial factors that can hinder implantation. And patient of which we start stimulation randomly in patient for fertility preservation. And in the area of COVID and coronavirus, a suspected or a positive patient for COVID-19 during embryo culture period. All these patients is frozen embryos and freeze all policy can help us to overcome these problems. We do have two techniques of freezing, as if all you know, the vitrification technique, of which ultra-rapid cooling in combination with cryopreservative agent to increase viscosity and decrease the freezing point. This technique is very effective regardless of the developmental stage of the embryo. And it's superior to slow freezing, and it's now an established protocol for ART cycles. In contrary, all the slow freeze do formate crystals, so that due to the solidification of water and alter the intracellular morphology. So, do we have benefits of using frozen embryo transfer or freeze-all policies? It seems yes. That freeze-all versus fresh show less chance of occurrence of ovarian hyperstimulation syndrome, less chance of miscarriage. It may improve outcome regarding preterm birth, low birth weight, small for gestational age, compared with the children born after fresh embryo transfer. In hyper and normal responders, frozen embryo transfer resulted in a statistically significant increase in ongoing pregnancy rate, clinical pregnancy rate, and a trend toward less miscarriage rate. However, this article is dated long back, 8 years ago, and we will discuss this in a later slide. Frozen solid embryo transfer cycle were associated with significantly lower risk of ectopic pregnancy compared to fresh cycle. On using euploid embryo, optimal evaluation of the embryo before embryo transfer, a huge benefit could be extracted from the use of day 6 frozen blastocyst with the exact success rate compared with day 5 blastocyst, so that slowly developing embryos reach blastocyst as day 5. We can use them instead of losing them. But do we have downsides, complications, risk of using frozen embryo transfer? It seems yes. Frozen embryo transfer in PCOS patients significantly cause preeclampsia, 4%, neonatal deaths, 1%, and stillbirths, 0.5%. Although stillbirths occur in this article in just 2 cases, but still this is a major incident and need invasive investigations. In normal responder, patient without ovarian hyperstimulation syndrome, transfer of frozen embryo didn't result in higher implantation rate, ongoing pregnancy rate, or live birth rate. In same category of patients, in ovulatory women, frozen embryo didn't result in live birth rate, implantation rate, clinical or ongoing pregnancy rate in another set of patients. The altered birth weight is not only the effect of frozen embryo transfer, but cryopreserved embryos may affect occurrence of adult disease, epigenetic instability, and imprinting disorders. Not only this, the Danish Medical Birth Registry, which published last year, they published the data of more than 1 million child And the cancer risk increase among these children born after the use of frozen embryo transfer. The risk is 2.4. And lastly, a new article published about 1.5 months ago, a Chinese article, discussing the effect of storage time after vitrification on pregnancy and neonatal outcome. And there is a clear decreased chance of biochemical pregnancy, clinical pregnancy, and live birth rate after passing more than 2 years of storage. The cost effectiveness of the freezing embryos cannot be ignored, and the incremental cost per 1% additional live birth rate for the freeze-only policy versus fresh embryo transfer strategy was more than 30,000 euros. So it's not only the science, but also money, which can affect your decision to use frozen embryos. So take-home message: the frozen embryos can decrease ovarian hyperstimulation syndrome, especially in patients with polycystic ovary syndrome, and the free clinic could be a reality based on this policy. Using this policy, you can nullify the effect of endometrial advancement. You can enhance the embryo-endometrium synchronization. Also, you can use slowly developing embryos with day 6 blastocyst. The freezing may decrease the chance of ectopic pregnancy, and it allows for optimal timing for patients who will perform VGTA. If any freezing may avoid the effect of premature progesterone elevation. And if beneficial, freezing may allow oocyte collection for patients with poor response. But the risk and drawbacks of using frozen embryo transfer seems to arise from in ovulatory women and normal responders. The freeze-all policy didn't result in higher rate of implantation, ongoing pregnancy rate, or live birth rate. The frozen embryo transfer significantly caused preeclampsia, stillbirth, and neonatal death. The potential extra cost cannot be ignored. The frozen transfer policies result in definite delay in treatment with the expected emotional burden on the patient. The frozen policy is inherited with a potential risk such as childhood cancer. Thank you.
MENA Pharm is an industry-leading pharmaceuticals company with a proud heritage of over half a century of experience in delivering cutting-edge technologies to produce the highest quality medicines. MENA Pharm is breaking boundaries and challenging industry norms in the pursuit of excellence. To fulfill this purpose, a clear vision of future expansion has come to fruition through multiple alliances and partnerships with specialized companies around the world.
We at MENA Pharm established the first research community in Egypt and the Middle East. Our team is composed out of young talented Egyptian scientists and European experts. Together, we develop high-quality and cost-effective genetically engineered drugs.
The development of complex genetically engineered medicines in Egypt is supported by MENA Pharm's German subsidiary, a global provider of intelligent proprietary technologies for the biotech industry at large, with a firm commitment to breaking down scientific and economic barriers.
There is substantial evidence that a new age is dawning for Egypt to offer exceptional opportunities, and MENA Pharm is perfectly positioned to ride into the future with life-saving and life-enhancing, innovative and yet affordable products.
Striking the balance between innovative and affordable medicines is the mantra at the company's core, allowing MENA Pharm to play an important social role by responding to the complex challenges of unmet medical needs of emerging countries. MENA Pharm's desire to overcome these challenges helps the dreams of the next generation to be fulfilled.
Thank you. Let me first thank our eminent speakers for such a stunning, successful webinar for the IVF giants, as just mentioned by Professor Sabri. Thank you, Professor Badawi. Thank you, Professor Balson. Thank you, Professor Khalaf. And of course, thank you, Professor Sabri, for preparing such an amazing meeting. Thank you, Professor Fawzi. MENA Pharm. We MENA Pharm Pharmaceuticals, we believe that innovation made affordable. MENA Pharm is the first company to introduce a biotech facility in Egypt, North Africa, and Middle East. MENA Pharm Pharmaceuticals offered the Egyptian market an exceptional gynecology portfolio. Feridional, a breakthrough technology for the treatment of the iron deficiency anemia. Betelvex, the true debut vitamin B12 with a once-weekly dose. Dicinone, the most tolerable hemostatic for capillary bleeding. From the beginning of the story, with such a prominent existence in the Egyptian pharma market, it wasn't enough for MENA Pharm to offer the highest quality pharmaceutical products for the unmet medical needs. But MENA Pharm decided to invest in the biotech for the medical production. Striking the balance between innovation and affordability, MENA Pharm established a joint venture with a German biotech company, and the result was Rhine MENA Pharm, which is dedicated to research, technology development, and know-how transfer for genetically engineered recombinant products, achieving affordable local medicinal solutions. Till we come to the step of provision, the intelligent biopharmaceutical solutions. As MENA Pharm decided to prepare the biotechnology medicinal products from the scratch. MENA Pharm is the first and still the only Egyptian company to acquire a German biotech company in a unique business model. Such news gained the focus of the press, and it was published in many strategic Egyptian and European newsletters. Indeed, it's not ordinary that Egyptian company acquire German one, not only from the pharmaceutical aspect, but also from the economic aspect. And here we come to our hero today, the Gonapure, the recombinant follicle-stimulating hormone. The production process of Gonapure occurs in 3 facilities. The first step starts in provision, where it produced the cell bank to be delivered to Rhine MENA Pharm, where fermentation and purification occur to produce the purified protein. So, Rhine MENA Pharm is not going to produce product, but product substance to be delivered to this purified protein to MENA Pharm, where lyophilization and filling occur, and of course, packaging. And now, we come to the last step. A sample of each produced batch will return back to provision in German for the quality assurance. And now we have Gonapure in the hands of our dear patients. Gonapure has a dual nationality. Yes, Gonapure is an Egyptian recombinant product, but with German technology. As Gonapure is manufactured in Egypt, thus continuous availability with no stock rupture. Also, best storage and transportation guaranteed hand-to-hand delivery. And today, we are celebrating with you 5 years of prominent existence in the Egyptian pharmaceutical market with trusted efficacy and safety. If we calculate the average cycle cost in terms of 30 vials of 75 international units per cycle, we will find that Gonapure is the most economic cycle, not only if we compare Gonapure by other recombinant FSH, but even if we compare Gonapure with highly purified urinary FSH. Still, Gonapure is the most economic cycle. To sum up, Gonapure is an Egyptian recombinant follicle-stimulating hormone with German technology. Gonapure no patch-to-patch variability, guaranteed purity and efficacy. Gonapure better quality of oocytes and embryos, thus better implantation. Gonapure glycosylation structure resembles human and thus no reaction at the site of the injection. Thank you. And now we will complete our Q&A session with the Professor Khalaf and Professor Sabri. Thank you.
Now for the question of Professor Yaqub Khalaf, مسك الختام. We have the first question for you, Professor, from Dr. Nahla Magid about the dose of estrogen we continue whether we continue the dose of estrogen the same if pregnancy occur or to reduce it.
Yes, it's an interesting question. In actual fact, people who used to use 6 milligrams, they used to make them 8 when the patient is pregnant. So if anything, you increase it a tiny bit or maintain it the same, but not to reduce it.
Yeah. Okay. The second question from Dr. Juthia. Which patient will you will use GnRH down regulation in human replacement cycle in frozen embryo transfer?
There are becoming very few, and the patient will use down regulation who had frozen embryo transfer with us 3-4 years ago, and we did down regulation and she had a baby. So we will not change something that worked for her. And patients who have adenomyosis or endometriosis, just going by conventional wisdom that it would be helpful to down-regulate endometriosis before frozen embryo transfer. Those are the only 2 people that we will use, 2 categories that will use down-regulation. Otherwise, it's just HRT.
Okay. Another question is the luteal phase support or the progesterone per se have any modification or any role to add for cycle of repeat implantation failure?
For what, sorry?
For cycle of repeated implantation failure.
So meaning that you can modify the luteal phase
Yes.
support or you freeze.
Yeah, yeah.
No, there is no modification really that is based on evidence that I know of, because let's ask ourselves, what causes recurrent implantation failure? Most of the time they are embryonic. If the uterus have been excluded, doesn't have any abnormalities from what Professor Bedewi is spoken about, then if it's embryonic, you will not change it by manipulation of that hormone and adding a bit of this and a bit of that. All of these have been tried. They made little difference.
Another question from Dr. Jihan Mustafa. Do we have any special preparation for frozen cycle transfer or for the luteal phase support for cycles of endometriosis?
That's I mentioned. It would be sensible to go with down regulation of the cycle, and although some people will do natural cycle, because some endometriosis patients will have perfectly regular ovulatory cycles. But generally speaking, according to the best available evidence, down regulation might confer some benefit.
Another question from Dr. Latif. What is your protocol or your preferred methodology to manage cycles of repetitive endometrial fluid before embryo transfer?
This is a difficult one that requires investigation first before management. And if you have excluded any hydrosalpinx, and sometimes people do not consider a patient who had ectopic pregnancy and had emergency partial salpingectomy, the stump of a scar tube can collect fluid just as much as a full hydrosalpinx. And that could be the result of the fluid that's coming into the endometrium. Presence of any fluid usually is not conducive to good endometrial development. If you excluded this, if you excluded adenomyosis, because in some adenomyosis cases, you will find increased secretion of the adenomyotic tissue and leading to also collection of fluid. If you excluded chronic endometritis for whatever it's worth, because it depends on the setting, then that's all you need to do. Sometimes, if you have nothing of that pathology, give the patient the progesterone. So if you have blastocysts, give the patient progesterone for 5 days. And on the day of embryo transfer, scan her. If that fluid disappeared, go ahead and put the embryos back. If the fluid persists, then cancel the frozen embryo transfer and prepare the patient for hysteroscopy to see if there is non-discernible adhesions or scarring that could potentially be treated and make things better. That's what I would do.
Okay. We have a question from Dr. Adil Al-Baghdadi. What is the cornerstone of progesterone in frozen cycle transfer?
Meaning?
This is the question. I think he mean what is the cornerstone of the dose and when to start it?
Yes. Okay. So, okay. The dose is 400 milligram twice a day if you are using vaginal progesterone like cyclogest. If you are using Crenone, it is 90 milligram one application. If you are using Bronchogest as Uterogestan, it's also 800 milligram. If you are using Lobion or the equivalent, the subcutaneous progesterone is 25 milligram subcut. If you are using intramuscular Gestone or Bronchogest, 50 milligram should be adequate every day or 100 milligram every other day.
We have a question for the luteal phase support. Do we need to measure serum progesterone and assign doses accordingly, or just one protocol for all patients?
One protocol for most patients, as long as they are all within reasonable BMI. If you have a patient whose BMI is 55, then A should not be treated in the first place until she loses weight. But if you happen to have a stubborn patient, then you might need to increase the dose of progesterone. You give her double and good luck.
Okay. You mentioned in your talk no difference between vaginal and intramuscular progesterone.
Yeah.
But do you suggest intramuscular has better result for continuing pregnancy?
but that is contradiction in what I said. If I say there is no difference, it means that does not have higher pregnancy rate.
Yeah.
Okay, so it is being studied until the cows came home. Absolutely no difference between the two.
Okay. From Professor Subhi Abuloz, for how long time to give progesterone during pregnancy?
Until our dear professor and great man, we give it until 12 weeks if we are using it for frozen embryo transfer. But if for fresh embryo transfer after the first pregnancy scan, usually at 7 or 8 weeks, and we see the fetal heart pulsation, it has no place whatsoever because there is plenty of HCG and it is able to support itself at that stage.
Is there a cutoff level for progesterone to transfer or to cancel cycles?
No, I mentioned that. What is being suggested is 9.2 will be associated with lower pregnancy rate. It is really arbitrary and it has not been validated with the admission of the authors themselves. So we should not go with something just by suspicion.
Yeah. Dr. Muhammad Ihab, for frozen embryo transfer, we usually depend on both thickness and echogenicity. Is it still the valid approach?
I'm not sure what you mean about the echogenicity, because the echogenicity we cannot change. If it's echogenic, you're stuck with it. There is no intervention that will move it from echogenic to triple line. Thickness, yes, because if you use it for 10 days and the endometrium is 7 millimeter, you give it a few more days, you will get 9, you will get 10, fine. But echogenicity is really inherent to the endometrium itself and it can't be altered.
Okay. Another question from Dr. Amil El-Jizani. If endometrial thickness on day 8 of the cycle, 8 millimeter, shall we start progesterone? And if we...
Okay. Yeah, you can start progesterone, but my advice, don't bring the patient so early. Why are you bringing so early? If you emulate nature, the follicular phase is at least 12 days. Just bring her on day 10, 11, or 12. Where is the hurry? But if you had to start after 8 days, it's fine. Yeah.
And if we start progesterone on day 10, shall we did frozen embryo transfer on day 15 of the cycle if endometrial lining is okay, regardless of the progesterone level?
Progesterone is not measured. I showed you our result and I showed you our practice. We don't measure progesterone. That we don't measure it. Plus, it's a big mistake to relate the replacement of embryos to day of the cycle. You replace the embryo in relation to the number of days you have been giving progesterone. It's nothing to do with the day of the cycle, because you could have given estrogen for 15 days and then 5 days of progesterone, and on day 6 of progesterone, you put the embryo. So don't relate it to the length of the cycle or the day of the, relate it to when you start progesterone. If you start progesterone for a day 3 embryo replacement, you give the progesterone for 3 days, and on day 4 you put the embryo. If it is blastocyst, you give progesterone for 5 days, and on day 6 you put the embryo back.
Question from Dr. Ahmed Badruddin. Is there any alternative that you prefer or use to determine the window of implantation other than the ERA test?
The ERA test does not, Dr. Ahmed, as we discussed, and there is no alternative. We work with the conventional wisdom. The conventional wisdom, when you start progesterone, the relationship of the time when the embryo should be put back is related to the stage at which you frozen the embryo. If it is 3 days, then on day 4 of progesterone, you put it back. If it is blastocyst, on day 6 of progesterone, you put it back. Any trial to follow the endometrium and to follow some judgment here and there, it is totally and utterly impractical. I'll give you an example. I had a patient from the Gulf who had to have her embryo, that is blastocyst, and BGD for translocation on day 4. Normally, we would put it 5 days after progesterone. But the last flight to leave London was it was not ideal. I put it back. and the patient traveled and she had a positive test and she has an ongoing pregnancy now. So there is a modification and there is a range within biology that accommodates this variability. It's not exact science.
Another question, I think Professor Yaqub commented about the measuring of progesterone, but we have, if it is below 10 nanogram per milli, we have implantation failure or not?
The figures that I have showed does not show implantation failure. It gives 33% clinical pregnancy rate.
Yeah.
Okay.
But if we obtain the high level, there is no pregnancy either.
No, the high level, there is nothing called no pregnancy. Okay. There is there is maybe lower chance. People suggested that too low is bad and too high is bad, progesterone. This is really a bit of statistical anomaly more than anything else and need to be corroborated. There is nothing physiological to bear this out. And we should not, as I always say, we should not go by every paper we say. Okay.
A question from Dr. Sharif Badran. Does endometrial thickness linearity correlated with pregnancy rate if embryo transfer at a more than 7 millimeter diameter?
A more than 7 millimeter until maybe 12, 13, it doesn't make huge difference really. There is no linear correlation, but certainly on the extreme, 5 will be better than 4, 6 will be better than 5, even marginally. 7 will be better than 6, etc. But this linearity is within the normal. Okay.
A question about the preparation of persistently thin endometrium for a patient who has for a thin endometrium. A question of persistently thin endometrium.
Yeah. Persistently thin endometrium will depends really how thorough the investigation is. If you ruled out atypical endometrial adhesions by a very expert hysteroscopy, if you ruled out chronic endometritis, if you ruled out underlying adenomyosis, if you ruled out all of these aspects and you have persistently thin endometrium on healthy uterus, I would go with endometrium of 4 or 5, whatever I have, because there is no way you will make it any better. And pregnancy rates, as we demonstrated in that big series, still happen with endometrium of 4 millimeters.
Okay, Dr. Souza, need a re-explanation of you. Dr. Professor Yaqub mentioned that, but he need to re-explain how many days we need to give progesterone before embryo transfer, according to whether we are using natural, modified natural, or artificial.
That's a very practical question, and it's worth explaining even 100 times. Okay. When we have natural cycle, assuming that the patient has a regular 28-day cycle, if we use the modified cycle, we have taken things in our hands. When we give HCG, that is equivalent to the LH surge. Usually ovulation will follow LH surge by 36 hours. For practical reason, we say 2 days. So if I gave it on Wednesday, on Friday, this patient will supposed to have ovulated. The ovulation day is equivalent to the day of egg collection. So if we do the egg collection on day 5, we put it on day 6. So if we did the egg collection on Monday, we do the embryo transfer of a blastocyst on a Saturday. So you have 2 days before, which make it 7 days. So if you have a natural cycle, or you gave the surge today on Thursday, on Wednesday next week, you do the embryo transfer. So 7 days from when you have given the HCG, which is replacement for the LH surge in the natural cycle. So that should be straightforward. You always go for 1 day less than the day when you gave the HCG to make it 7 days. When it comes to the artificial cycle, it depends on what stage of development you have your embryos frozen at. If you have frozen on day 2, which is perfectly fine, you give progesterone for 2 days, and on the 3rd day, you put the embryo. If you have day 3 frozen embryos on day 3, you give progesterone when the endometrium is the right thickness, you give progesterone for 3 days, and on day 4, you put the embryo. You always add 1 day. And if you have blastocyst, you give the progesterone for 5 days, and on day 6, you put the embryo back. That is what we use religiously and what gives us those not so bad results.
Question from Dr. Jihan Mustafa. Is there a relation between endometrial thickness, number of embryo to be transferred, and implantation rate?
The number of embryos to be transferred will always be associated with lower implantation rate, but that is nothing biological, it is mathematical. Because if your denominator is high and your numerator is that's the number of sacs that you work out the implantation rate, the ultimate calculation will be always low. If you put fewer embryos, your implantation rate will go up for nothing other than putting fewer embryos. And that has been, I suggest to you to read a paper in Human Reproduction written by George Grisinger. It says why implantation rate should never be used as an outcome measure, because it varies depending on how many your practice of embryo transfer. That's why in the UK, the headline figure to represent success of different clinic is the live births per embryo you transfer, not per embryo transfer procedure, because that encouraged people to replace fewer embryos. And that's what got us to 8% multiple pregnancy rate as of today. The latest figure, 8% multiple pregnancy rate in the whole of the UK with all patient profile. Okay, so the implantation rate, when you relate it to the number of embryos, the lower the number of embryos you replace regularly, the higher your implantation rate would be.
Okay. Another question from Dr. Ashraf Selima. Is there benefits if from adding HCG in the programmed estrogen progesterone frozen embryo transfer cycle?
There is no need really to complicate things further, because you are going above nature. Because naturally there is no HCG to receive the embryo. Embryo produce HCG. Why are we trying to do one better over nature? Yeah.
Question from Dr. Professor Muhammad Yusuf Abdel Fattah. Do patients with endometriosis benefit more from freeze-all policy?
There is no evidence really to suggest that, but there is practical necessity. If you have a patient with polycystic ovaries with endometriosis, it does happen sometimes, they come together. Then in order to get the benefit from the antagonist cycle and the agonist trigger, of which you are expert, Dr. Muhammad Abdel Fattah, you then can freeze all, and you can use the benefit from using down-regulated frozen embryo transfer cycle. So you give the benefit of safety by using antagonist-agonist trigger and getting as many embryos as is safely possible, and using the effectiveness that the Cochrane review suggests that we have by using down-regulated programmed cycle.
Again from Dr. Nahla Magid. In the luteal phase support with artificial cycle, shall we reduce the dose of estradiol if pregnancy occur, or keeping if same starting dose? And what is the dose of
vaginal progesterone is 400 milligram twice a day.
Dr. Shadia, does intracytoplasmic sperm injection with pre-implantation BGS has a role in patient with recurrent molar pregnancy?
I'm not sure really, because not all molar pregnancies are the same. If there are some that resulting from 2 sperm fertilizing 1 egg, doing ICSI on its own should sort out the problem. You don't need PGS because you are ensuring that there is only 1 sperm. But if it is the division of 1 sperm or something that is not clear to me, it's called didandric and familial, that defies any logic. And we had one who has repeated moles, and we did PGD, not PGS, looking for particular. All the embryos were normal. Okay, so you can't trace anything in those patients. It's not straightforward, and it's better refer to a specialist.
Okay, from Dr. Ashraf Dewidar. So how we can counsel the couple about frozen embryo transfer? As you stated, there is increased risk of stillbirth and childhood cancer.
Again, I never mentioned the words childhood cancer. It is mentioned in previous discussion. It is mentioned in a paper, but it's all about putting it in perspective. Even with the assumed increased risk of childhood cancer, it makes it 1 in 2,000. 1 in 2,000, meaning every 2,000 children resulting from frozen embryo transfer, there will be added one with risk of cancer.
Yeah.
Like I say, 3% of babies born from IVF, regardless, will have major congenital anomaly. Major mean that it interferes with functionality, and it has not stopped people from trying. So people need to put it in perspective. 1 in 2,000 is not something that should be a cause for alarm.
Another point to comment from Dr. Osman Mariam, she's asking about how long can we store embryo frozen based on the last Chinese study. They would like to know your comment about this this study and this issue.
Yes, this study is just published last week, actually.
Yeah.
Is indicative that the longer the duration of storage with vitrification, the lower the chances of success. With any retrospective study, you need to be careful, because retrospective studies cannot exclude possibilities that they didn't consider, because they are dealing with an observation. The best way is to do cohort prospective study and look at those results in a large number. But going by whether it is Chinese, whether it is Japanese, whether it is Egyptian, retrospective study is good at generating hypotheses, is not good at providing evidence.
Okay. Question from Dr. Jihan Mustafa. Is frozen embryo transfer more effective than fresh embryo transfer?
It's not. In absolute term, it's not. Okay. And the only studies that unfortunately have shown that in PCOS patients, frozen embryo transfer is higher than fresh in terms of success, you have question marks really, because patients are getting 50% live birth rate with putting 2 day 3 embryos. That just doesn't happen in real life. Yeah.
Okay. Another question from Dr. Sharif Badran. What about the rat tail endometrium with good thickness near the fundus and thinner downward?
I smell a rat here. I have never seen any rat tail endometrium. Sharif, you are just far too clever for your own good. Just go with what's common, Sharif.
And why not transferring in the part with good endometrium and go away from the tail?
It is a description really that I don't know a head or tail for it, because I've never seen it before. If you have endometrium that is in the majority of the end of the cavity of the uterus, and the patient have regular period from this and normal flow, you put the embryo transfer without busying yourself describing what the endometrium look like. But if she has very little period, scanty flow, then this patient needs hysteroscopy by expert to correct whatever adhesion that is causing the Arnab tail lining of the uterus. Okay.
The same questions for you, Dr. Sabri. Do you consider frozen cycle for this type of case?
I will go
until you achieve a better endometrium. You can try preparing it multiple times.
I guess no, because it's like the endometrium is inherited by its nature. The shape will not differ between cycle and cycle. So better you go and transfer in the good area using ultrasound, and that's it. Once you have endometrium more than 5-6 millimeter, it's good.
Okay. From Dr. Ahmad Nasser to Dr. Yaqub, is slowly growing blastocyst like day 6 or 7? What is the approach to deal is freezing them or transfer in the next cycle after estrogen progesterone preparation, or transfer them as a fresh with low success rate?
I can only describe our practice. Our practice is if a patient has any more embryos on day 3 than what we intend to put back, say she has 3 embryos on day 3 and we are planning to put 1, we have to take them to blastocyst. Our cutoff point for blastocyst transfer is day 5. So the patient come on day 5, we take the best available, 1 embryo to go back, and we keep the other for day 6 or day 7. Any blastocyst made beyond this stage and it is 3 BBA and above, we will freeze, whether it's day 6 or day 7. By the way, we have pregnancies from day 7 blastocyst culture.
And another question for you, Professor Yaqub. Do you prefer some type of embryo transfer catheter, and what is the causes of retained embryo transfer catheter? Is it the loading or the transfer procedure itself?
I think you are getting us into trouble with the embryologists now. There is variation in the way the embryologists load their catheter. It's not the only reason. And let's put it in perspective. Honestly, it could be a year without having one embryo retained in the catheter. So much so that in some clinics in the UK, they don't check the catheter after transfer. They take it as a given that it's gone. But for us, we do it. And every maybe 6 months, you get one, or every year, you get one that is retained in the catheter. Why I say there is variation? Normally, my understanding, the bit of fluid that should go into the catheter is about 15 microliter. But some embryologists, they give me enough fluid, you feel you are doing hycosi or saline sonography or something like that. You just inject with the whole of your force. Once you see that, you go and speak with the embryologist. What volume is that? Is that really fitting with the standard operating procedure? Have you discussed this with your senior? But gently there, because there is no abuse there. You get into trouble by abusing the embryologist. And and this is one. The second one, if you don't clean the cervical mucus, there are some patients who have thick cervical mucus. And if you're not using ultrasound guidance, also you are doing the navigation for a long time with the tip of the catheter, it can be retained, more likely than not. But retention of the embryo of the embryo in the catheter is not a reason to be pessimistic about the outlook. The only bit that affects the outcome of embryo transfer is difficult embryo transfer. Anything else is negotiable.
From Dr. Sharif Subhi, for the endometrium below 7 millimeter, for how long we have to wait before starting progesterone?
You don't have to wait anything, but if you have 7 millimeter and you did your scan on day 10 of estrogen, give it another week and then scan the patient again. If she does not have pathology, invariably you will get more than enough of your endometrium. But if she has pathology, if you kept her 3 months, the endometrium will not go beyond that. But usually it is much lower than the 7 millimeter.
Another question from Dr. Sharif also. What is the strategy that we can use for a patient with cesarean scar niche and endometrial fluid and embryo transfer?
Fine, you go and repair the niche. If there is fluid coming from this niche, you go and repair it or give it to someone who repair it effectively. But just because on ultrasound scan, some clever ultrasonographer told you there is a cesarean section scar niche when the patient is not having spotting, the endometrium is as dry as bone, it is developing with a triple line, you don't need to do anything. You just go ahead and do your embryo transfer. No symptom, no treatment.
I guess Dr. Sharif has a concern about hydrometra.
No, I'm just saying, but hydrometra, so the patient will have fluid. If she has fluid, that's for repair. If she doesn't have any symptoms, that's it.
Another question is if there is any preferences of estradiol patches over tablet, and when we use patch if available?
Most of the time we use estradiol tablets and they are very good. When sometimes we give the estradiol and we're giving 4 tablets, meaning 8 milligram, and the endometrium has not reached 8 millimeter by day 12 when we scan, then we add 2 patches twice a week, 100 microgram each, and they are available. It's called Evorel, and there is other preparation, but I don't know what is the situation in Egypt, but I know they are available easily in our hospital.
Okay. Another question from Dr. Hiba Saadoun. In artificial cycles, which is the best level of estradiol? And also, what is the best either step-up protocol of estrogen or starting and to continue with the same dose? And any of this will make difference?
We don't measure estradiol. There is no level. The best assay of estradiol is the thickness of the endometrium. If you give the estradiol tablets and you scan the endometrium after 10, 12 days, and it's 8 millimeter triple line, you don't need to worry too much about any assay. And as far as starting gradually or giving the full dose from the beginning, it's being studied, it makes no difference whatsoever. We use the same dose from day 2 of the cycle until day 12, until 12 weeks when the patient is pregnant. The same dose, 8 milligram per day.
Okay, another question from Dr. Sharif to you, to your good self, and to Dr. Muhammad Sabri as an indication for freeze all. The question is high progesterone in poor responder with low quality of endometrium an indication to cancel this cycle and start again?
Okay. I don't get the question.
High level of progesterone.
High level progesterone before
poor responder.
Yeah.
Yes.
With low quality endometrium.
I understand that it's not an indication for cancellation. It's an indication some people suggest for freezing. We discussed this repeatedly, and we said high progesterone 1.5 is not written in tablet of stone. It's not like, you know, a Bible. It is arbitrary. If you measured it at 11 o'clock in the morning, it's not the same at 8 o'clock in the morning. It's not the same at 2 o'clock in the morning. So you can easily ignore it. This is not your major problem. But if you have 2 or 3 follicles for this poor responder and you get 2 or 3 eggs, just go ahead and create the embryos and put them back, because freezing them will not do them any good, and the harm could be more than the benefit. So why complicate things further than it is necessary?
Actually, for me, I would go and see the endometrium using the ultrasound. The level of progesterone only without affecting the endometrium echogenicity make no sense. If you have high progesterone, you will see echogenic endometrium. So you go and try to see things together so that you can evaluate your patient one by one. And the level of progesterone is correlated with the number of oocytes. So the 1.5 for 3 follicles is not like 1.5 for 15 follicles.
Muhammad, you will not have 15 follicles in a poor responder.
Yeah. I mean, yeah.
Okay.
Yeah. Okay.
For Dr. Muhammad Sabri, the question is sent to you back again. How long we can freeze, how long we can the frozen embryo transfer stay in the tanks?
Actually, I guess we have embryos who put back after more than 15, 20 years. But the safety of this is not tested thoroughly. This paper, which published 2-3 weeks ago, discussing decreasing the success rate with increasing the years of freezing more than 2 years. So to respond to this question, how much is not validated till now, the results go down after 2 years and more, according to this publication.
A question from Dr. Marwa Sharaf to Professor Yaqub. What if we have a sick endometrium from day 6, triphasic, echogenic, and using the gestagen give no value for many times? What do you do for this patient?
What do you mean gestagen gave no value?
I guess she means she is doing withdrawal many times so that to get a new set of endometrium with no echogenicity.
But who said that giving the patient withdrawal bleed will change the echogenicity? So we create problem by inventing things.
Yeah, she's talking about sick endometrium from day 6.
Yes, thick endometrium from day 6, unless if you have excluded polyp, if you have excluded something that you have not seen, or polypoid endometrium, then there is nothing you or I or anybody can do. That's the nature of the endometrium for this patient.
Okay. Dr. Muhammad Zahi from Maghreb. a high progesterone on day of embryo transfer is bad situation for implantation. Do you think this still has a rule?
I don't understand the logic. Why
At
are
day
you
of
measuring,
embryo transfer?
why
Yeah.
are you measuring progesterone and the day of embryo transfer in the first place? Plus, where is the reference that has told you that high progesterone and how high is high on day of embryo transfer?
Okay.
Just try to keep things simple.
Yeah.
For yourself and for your patient, because when you complicate things, you make decisions that may be right, may be wrong. And wrong decision, the patient will pay the price.
A question for Professor Yaqub and Professor Sabri from Dr. Shaban Ibrahim. What action to be taken for pre-embryo transfer withdrawal, spotting, or vaginal bleeding?
Okay, if there is vaginal bleeding, you need to check. Just put a speculum and see that it's not coming from the cervix, because under hormonal effects, the endocervix sometimes can have a tiny bit of spotting. That has no relevance. You can still go ahead. But if it is that you find that the endometrium itself, it started to be degraded and coming and breaking down, then you need to stop, because the patient could have compliance issue. Should be taking the estrogen one day and stopping it another day. In which case, you need to make sure that you bring her almost every day to make sure she has taken the tablets in front of you.
For Sabri?
For me, I go and check the endometrium using ultrasound and go back and check my records. If the endometrium is decreasing, so this is a compliance issue and the patient is in his withdrawal, there is a withdrawal bleeding. If the endometrium is the same, so this is something else, and I will go and transfer.
If it wasn't decreasing, Dr. Mohammed, and you still on ultrasound find that it's breaking, does it make any difference?
Yeah.
It's either breaking or not. Whatever it was, history doesn't matter. Yeah.
From Dr. Jamil Abrash to Professor Yaqub, in artificial cycle without gene-rich agonist, do we need to see the ovaries, the ovarian activity, or just watch the endometrium?
You are there. You are not doing anything extra. Look at the ovaries to ليطمئن قلبي. But if you are giving 8 milligrams of estradiol every day, it is extremely unlikely for ovulation to happen.
From Dr. Shadia Hussein about the uterine niche again, does it affect the implantation if it is asymptomatic?
It doesn't.
No.
And it shouldn't.
Just a finding.
Yeah.
From Dr. Sharif Sobhi, in patient with high degeneration rate after sewing, it is better to freeze on day 3, better than day 5. What can I do in next cycle for Professor Yaqub and Professor Sabri?
No, I think this should be for Professor Mohammed Fawzi. What is that good to do with that? Generating embryos. Are we magician? That you have an embryologist, accomplished embryologist, to answer this one. So Mohammed, what would you do about
generating embryos is mostly we have to check the laboratory protocol and the embryo freezing system, as we should have 87 to 88 survival rate, either blastocyst or cleavage stage frozen transfer. If the embryo that cryopreserved was good quality.
Degenerating embryos is something that could happen sporadic or could be a trend. If it is a trend, then your lab need to be exploded.
Need to be
put a bomb in the lab.
Yeah.
If it is a sporadic one, these things happen and you put them into perspective. Yeah. Because if you speak to the embryologist, they will tell you that sometimes the tubing of the incubator can be kinked, so the gas does not go as it is expected. So the first thing they check in the morning, they find it's going pink, the culture media. You know that the embryos will be a mush the following day. So if that happened due to technical error, it's identified, and the head embryologist need to have a slap on the wrist, and you learn from it and you move on. But if it is a trend, then this lab is not fit for purpose, and you can make it McDonald's or something, but not embryology lab.
Excuse me, Dr. Fauzi, going back to the previous questions, the niche, the uterine niche, I would go and make a note for the doctor who will do embryo transfer, so that he should see the catheter thoroughly before doing embryo transfer. Sometimes, if you are not using ultrasound, you may go with your catheter inside the niche, and that's it.
Yeah. If it's in practice to use ultrasound, you need to be extra vigilant for that.
Yes.
Also, Dr. Sabri, what's your preferences, personal preferences with your cases? Do you prefer to freeze on day 3 or day 5?
Day 5.
Probably he knows the answer. Why is he asking you?
For Dr. Yaqub, what is the maximum estrogen dose in endometrium preparation in frozen cycle, in recurrent implantation failure, or for preparation of thin endometrium?
There is nothing special about recurrent implantation failure in terms of the dose of estrogen. You do not decide on the dose of estrogen based on history. You decide on dose of estrogen, decide on BMI, and on the response of the endometrium. Some patients may not respond in the same way to 8 milligram, then we can add patches, or we can increase by 2 milligram to 10, or sometimes even to 12. But take it from me, the patient who will not respond to 8, probably you will struggle with, no matter what you do.
From Dr. Muhammad, how many days of progesterone before day 7 blastocyst frozen blastocyst for frozen embryo transfer? He mean about the synchronization.
There is no synchronization. Day 6, you put it back on day 5. After, it is the same as if it is day 5.
It's blastocyst.
Yes.
Whenever she reached blastocyst, reached at 5, 6, 7, but it's the blastocyst.
Put it after 5 days of progesterone, and on day 6 you put it back.
Yes.
For Dr. Muhammad Sabri, also, if you have no blastocyst available in day 5, you have to transfer the morula stage or early cavitation or whatever, or to wait until day 6 or 7 and freeze and then transfer again in next cycle.
I go for the second choice.
Okay. From Dr. Shadi Hussein to Professor Yaqub, does Dowell stimulation protocol has a role in poor responder?
No, because whether it is not frozen, you mean it is fresh for fresh cycle. Whether you use antagonists or agonists, they are similar to each other. The problem is not Dow regulation. The problem is egg reserve. Whatever you do, that you are dealing with what the patient has got. She has got 3 follicle, 4 follicle. Whether you give her Dow regulation, long or short, it makes no difference.
Okay. From Dr. Shadia Hussein to Professor Yaqub and Professor Sabri, if there is an ovarian cyst in the first day cycle lower than 2 centimeters, shall I have to start frozen embryo transfer programmer?
If the endometrium is 10
and this is a programmed frozen cycle, should we continue this cycle or stop and seeking to solve the problem of the cyst?
The answer is simple. This 2 centimeter cyst is likely to be functional or just a follicle cyst. If it's functional, it will be producing estrogen. That is the very substance that we need to have on board. If it is not functional, it is of little relevance. So in either case, a 2 centimeter follicle cyst or cyst does not need to be touched, and you need to go ahead with your plan.
For Dr. Sabri, if you measure progesterone and you have a level of lower than 7 nanogram per milli, how do you increase this level? Persistent.
So at which time? Like it's frozen embryo, it's fresh embryo. When I did measure this progesterone.
On the day of embryo transfer.
Okay, for the fresh embryo, as Professor Yaqub declared on this study, levels between 5 and 10 has the same success rate, like between 10 and 20 and more than 20. So this make no difference. Actually, I didn't measure progesterone at the day of embryo transfer. First.
For Dr. Sabra, I know tomorrow you have a presentation about the freeze all. What is the top 3 indication for frozen cycle transfer from your recent preparation?
Okay, so the ovarian hyperstimulation syndrome, the BGTA, patient will do a BGTA, and patient on which we try to collect embryos at day 6, the slowly developing embryos, so reach blastocyst at day 6 and day 7.
Okay. For Professor Yaqub, from me, do we have the opportunity to know some unpublished data yet about the freeze trial of you?
We had the research, and unfortunately,
Mike, Dr. Yaqub, Mike.
We had the research meeting this morning at 2 o'clock in the afternoon. And unfortunately, the final analysis was delayed by COVID-19 because the statistical team was dispatched to focus on the recovery study that looking at COVID and done in Oxford. It's the same team. Yeah. So although the study is given a slot in the late breaking news at ISHRA, it still will go and present what has been done. The result will not be known before 3 months. Just to show you that when you do proper study, you don't know the result until the last minute, whether you are investigator or otherwise. Yeah. But I can tell you before we know the result that it will not be superior to fresh, and it could be even worse in patients who have fewer eggs, exactly as the common literature that we have now. Yeah.
Yeah, I saw it's amazing design and the novel outcome you specified in this study is a healthy baby.
Yes, yes, it's beyond 37 weeks and singleton.
Yeah. Lastly, what your recipe, Professor Yaqub, for those who will start tomorrow? To see patient for to decide which will go for frozen, which will go for fresh, and when we will go for frozen, which is preferred roadmap, and at the end, what when you decide to cancel a cycle in your clinic.
So, if I have a patient who has PCOS or has high antral follicle count or high AMH that put her at risk of ovarian hyperstimulation, I have one of 2 options. One is to give her a very small dose of gonadotrophin so that I try to get it right. I end up either getting 3 or 4 eggs for her, or 5 or 6 eggs if I was clever, and undermine her potential. And I may or may not get away with hyperstimulation, because if she gets pregnant, as they do, she can have late hyperstimulation. So I've settled myself. If I am concerned about hyperstimulation, I will give her a tiny bit higher than her standard dose. So if I normally give her 150, I'll give her 200. And I will get 20, 25 eggs, and I will have 18 fertilizing, and I will end up with 8 or 10 blastocysts and put them in the freezer. And this patient is sorted because she will come and have single blastocysts in the first couple of transfer, maybe double blastocysts on number 3 or 4 if she had to wait for that. And I have patients with this regime who have 3 children from one cycle, and still they have 5 embryos in storage. Yesterday, I was speaking to a patient who has 2 children, and she had 6 blastocysts, and she wanted to come and have frozen embryo transfer from the same cycle. Why are we ignoring that? Whenever we fulfill the patient potential, we are making her journey much more affordable. Yes, she pays for freezing, but the cost for frozen embryo transfer is a quarter of the cost for a fresh cycle. And we got rid of the headache of ovarian hyperstimulation. Yes, people might cast some doubt about safety of frozen embryo transfer in terms of large for gestational age, in terms of hypertensive disorder in the mother. All of that is surmountable. If you use natural cycle in the appropriate patient, those downside could be, at least the maternal side of preeclampsia and hypertensive disorder could be sorted. So that's what I use.
Last, I have been honored to be with you in this webinar, and I leave the last comments and from a scientific and personal perspective to the man who was behind the organization of this meeting, was Dr. Muhammad Sabri. He assigned this meeting to me as a moderator, but he prepared everything. I did nothing in this. So Dr. Muhammad Sabri, please, the mic is yours.
Thank you, Dr. Fawzi. Actually, I'm very happy of having Dr. Yaqub, Dr. Bidewi, and Professor Paulson with us. I'm very happy by your moderation. We hope Upper Egypt assisted group continue preparing these webinars and to have more than just webinars. And in a later time, we'll declare what's going on, what's on our minds. And thanks for the attendees who stayed with us more than 3.5 hours till now. Same number of attendees, same jealous to have science and cooperation. Thank you.
Pleasure.
Thank you very much, Professor Yaqub.
Thank
you
you
very much. Thank you.